Good morning, everyone. Try that again. Good morning, everyone, and welcome to the July meeting of the Universal Health Plan Governance Board. Special welcome back to our board member, Bruce Goldberg, who's joining us again today. And let's get started with a roll call.
Helen Belanca,
Here.
Chun-Wei Chi,
Here.
Amy Fellows,
Here.
Michelle Glass. And I'm not see Michelle yet. Bruce Goldberg,
Present via video.
welcome back. Judy Richardson. Oh,
Here.
no. Cheryl Ramirez.
Here.
Mary Lou Henrich.
Here.
Mike Leahy.
Present.
And I saw that Michelle just joined. Let me give her audio permissions. Welcome, Michelle. Are you here?
Yes.
That's everybody.
Great, welcome everyone. So a quick agenda review. We have a brief consent agenda, and then following public comment and the executive director's report, we'll have an update from the Community Engagement and Communications Committee. And then Bruce was going to give us an update on the Medicaid Advisory Group that he's been participating in for the past 6 months. We will be hearing from Morgan Shook from Echo Northwest about some potential economic impacts of our plan. And then the bulk of our meeting today is going to be focused on our revenue plan, incorporating some of our discussion from our last special board meeting, and making some decisions. This is potentially our only voting topic. We may be voting on a final revenue strategy today if the board feels moved to do so. And then we will be moving on to an update from Lee about waivers. As the board recalls, we had a discussion last month about whether or not a Medicaid waiver would be needed if we keep basically the benefits the same, and good timing that Bruce is back for that discussion, but Lee will be giving us an update on what she learned in that regard. We'll have a brief agenda item about information technology with the Universal Health Plan, and that should wrap up our meeting. So again, only one possible voting topic today. And so we will go at this point on to public comment. In terms of written public comment, we heard from Jeff Hance, who wrote to encourage us to consider a sales tax as preferable to an income tax. Sadie Taylor wrote with concerns that the Death with Dignity Act could be expanded to allow for medical aid in dying for people with non-terminal conditions, as has happened in other jurisdictions. And she points out that there is some inherent bias in healthcare that would affect those decisions. She asked the board to consider protections against that. Rachel Neff wrote in support of a universal health plan for people like her with orphan diseases that have very expensive treatments. Darren Henry, Evelyn Alford, Elijah Ullman wrote with general support for universal health plan. An anonymous person who identified themselves as a senior citizen said that they were deeply opposed to a universal health plan, saying seniors already are moving out of the state due to other disadvantageous taxes, and this will increase that. Dr. Joanne Holland wrote with concern about the loss of direct primary care or concierge model payments. She proposes that the UHP include a direct payment to primary care providers to accommodate their ability to see patients. Eva May wrote asking us not to exclude vision, dental, and fertility services from our benefit plan. Warren George wrote in with multiple comments, and I encourage the board to read through those thoroughly, but briefly he noted that economic growth may help us keep pace with healthcare costs. He mentioned that there may be revenue from liability insurance, such as workers' compensation, and he encouraged us to fight for fair Medicare reimbursement as Oregon lags the national average by 25%. He mentioned the Elway poll done in 2019, where respondents were asked to guess how much a tax would be to cover universal care, and the guess was about 12%. and that many were willing to pay 2 to 3 times their current income tax for universal care. And finally, he commented that the finance plan is complicated and recommended that we frame it as an income adjusted premium. Again, it's a detailed testimony. I encourage you all to read that. And then finally, Eric Humphreys wrote with the observation that paying clinicians higher than OHP rates may have the effect of drawing more clinicians to our state. And with that, we will go to the oral comment on voting topics. So we have 2 people who have signed up to provide oral comment on our voting topic, which again today is the revenue plan. And first up is Alex Polikoff, if you're ready.
Thanks. Can you hear me okay? I'm not seeing my video come up. So.
Yes, we can hear you.
Great. So first, thanks for the opportunity to comment. I want to support the board in using the levers that were considered at the July 9th meeting, you know, especially the tiered rates and Medicare phase in. There was also some talk of potentially lowering the HCPIT, the tax credit from the EPT. One thing, though, that was not discussed that I just wanted to mention, thresholds were not discussed on both the EPT and the HCPIT. The EPT threshold at 500K was just an arbitrary number coming out of the F&R committee. The board should consider lowering that to something like 300,000 and having LRO look at that and what impact that would be. The 200,000 threshold on the HCPIT, there was some rationale for that, looking at both Medicaid and the basic health plan. But I think the board should consider lowering that threshold in the phase in to something like 150 and have LRO look at that. I think a broad-based low rate tax plan is always going to be the most palatable to the public. And the board should consider all levers so that can be implemented. Just lastly, I just want to support those board members who have been pushing back on the Milliman numbers. I think, as you look at what you need to do to get the tax rates down to make it acceptable to the public, those numbers are extraordinarily high. And I support those who are looking at using more realistic replacement numbers. So thanks for the opportunity to speak. And again, thanks for all your work.
Thank you, Alex. And next is Tom Sinzik.
Hello, everyone. Again, thank you for all your work moving this forward. I saw an expansion of the draft report, more work being done. As far as the revenue thing, I just want to comment. I guess you all know, and I guess just the obviousness is this will have to continue to be worked and reworked all the way into the legislative session as input is gathered going forward. So making sure that this is our initial thoughts versus the recommendation, I think, is kind of like the play that the wording that needs to be put out. But it was mentioned about other places where you could think about revenue and it was just mentioned, things like homeowners insurance, medical, we created auto insurance, there's dollars there. And then in terms of savings, which is also could be considered revenue, and I'll have more on this later in another meeting, which is we can really simplify the eligibility requirements. It's a bureaucratic mess in terms of what's written there right now. And I think if you simplify it, you're going to create and reduce administrative cost in operating the system. So I won't take up any more time than that, but thank you for your work.
Thanks, Tom. And again, the board would like to express their gratitude to all the members of the public who take the time to write in or call in and participate in person in our meetings. We really appreciate all of the input. Next up, we have a consent agenda, which today consists of just 2 items. It's the meeting minutes from our regular June meeting, plus the minutes from our special July 9th meeting. Those are the 2 items on our consent agenda. Do I have a motion to accept those minutes? So moved.
Second.
Great. Any discussion about those?
I have a couple of minor things to Isabel.
Great. Okay, then we can do a roll call vote.
Helen Belanca,
Yes?
Chun-Wei Chi,
Yes.
Amy Fellows,
Yes.
Michelle Glass,
Yes.
Bruce Goldberg,
I'll abstain. I was not there.
Judy Richardson.
Yes.
Cheryl Ramirez.
Yes.
Mary Lou Henrich.
Yes.
Mike Leahy.
Yes.
Thanks, everyone.
Great. So I'll pass it over to Mimi for the executive director's report.
All right, thank you, Chair Blanca. Good morning, everyone. I'm Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. We'll start off with some updates. So board member recommendations were submitted to the governor's office on July 1st, 2026, to have people to fill the positions that are going to be becoming vacant. Goes to the governor's advisors, and then they submit a recommendation to the executive appointment team. Actually, they had to have it in by yesterday, July 15th. And then the announcements will be made during September legislative days. So that's when we'll hear who the governor's office has picked. So just to remind everyone, we'll have a new appointment who will be taking the seat of Michelle Glass on October 1st. And then Amy Fellows' seat that new person will begin on January 1st. And then Helen Belanca actually has renewed her board position, so she will continue. Her renewal starts on January 1st of 2027. All right. So next, I wanted to talk a little bit about the accessibility of the materials that people are receiving. You may or may not have noticed that there's been just a slight change in the formatting that we have of our agendas, some of our printed materials, and of our slides. So because federal and state regulations and also through the agency DCBS to improve accessibility, especially for people of low vision, we are required to have everything that is posted to our site or sent out to meet certain accessibility requirements. So just a note that that's what's going on. When we receive things from a third party, say from a consultant, they don't have to meet those standards, but anything that's created by the board or say by a board member does need to meet those standards. All right. I also wanted to talk a little bit about some of the work that has been going on. I'm sorry, because I don't have a bullet point here about our the legislative concepts that have been proposed and are very much in the process of being worked on. As people we've talked about, that there are two. There's a phase 2, which is really continuing the work of the Universal Health Plan Governance Board and funding in 2027 to 2029. And then there's also a framework of the Universal Health Plan, which will be going forth into the 2027 session. We are extremely fortunate in that we have great champions. Senator Patterson certainly leading the way and other legislators as well. We are working closely with advocacy groups. We have the Legislative Policy and Research Office has been instrumental. We have working with Legislative Council, Legislative Fiscal Office. So there is an extreme amount of work that is happening and more updates will happen as more things gel and come together. One thing that I would like to point out, and I think Bruce Goldberg might talk about this a little bit too, that especially when we think about these legislative concepts, the work that has been done with the governor's advisory group on Medicaid sustainability, there's a tremendous amount of overlap, especially when we think about administrative simplicity that they have recommended. So again, it's like a very positive thing, and there's a lot of momentum right now. So I say that as a bit of an encouragement that things are moving forward and there is a lot of alignment. Next, I've had a request a couple of times to talk about what's happening in Washington State. So very briefly, Washington State has a Universal Healthcare Commission. They don't have a timeline for a specific report, but they do give annual reports. And I have the links, those are there on the slides if you want to look at it. We are fortunate enough that we get to meet with the people from the Washington Universal Healthcare Commission monthly, and and also with people working on it from California. So we definitely exchange information at those sessions. Currently, Washington has completed their eligibility work. They've completed their benefits and services. They're in process of working on cost containment, provider reimbursement and participation, and also enrollment. And on deck, they have, or upcoming rather, they have financing, infrastructure, and governance. So they too still have they have a significant way to go. I will say for Washington's eligibility, their eligibility encompasses everyone in the state with the exception of the Medicare population and also people who receive health insurance through the federal employee health benefits and TRICARE. And their benefits and services, they have a uniform medical plan, which they believe they will roll out at about 87 to 90% of actuarial value. So they are anticipating having some income coming back in. They are also including dental. I thought I wanted to make sure that I put that in there. So again, really encourage people to look at their website. It's great. A lot of very interesting information. And then lastly, just our working budget. We are still in the black. Not too much has changed. So all good news. And that is it for me. Thank you.
Do you want to mention anything about the report, draft report?
Oh, the draft report. Sorry about that. Thanks. I left that one out. I appreciate that. Thanks, Chair Blanca. So the draft report, draft number 3 is available and has been sent to all of the board members. It's also being posted on our website. This is the opportunity that board members have to weigh in. Again, we're not asking for line item edits, but really to comment on the substantive nature of the report, because as these portions are being finished, they're then being sent to our communications team at DCBS for final editing. So there is not going to be a lot more opportunity. So the time is now. And so to make edits, have discussions, if there are significant big issues, that's certainly something that would be, brought forward to staff, brought forward to the Chair Blanca. But the window is getting closed. So people do need to jump in when they can, and I'll pause there for a second.
Go ahead, John.
So when is the deadline for us to send in edits? You may have said this somewhere, but just to clarify.
So I'll turn it over to Lee.
Yeah, the current one I listed was, I think, July 27th. However, just so everyone knows, following this meeting, I've got some new draft sections. So if you haven't looked at it, you might just want to wait like 5 days, because I think by Monday or Tuesday, there will be draft number 4 coming out.
And our edits will be due this 27th still.
Usually I do about 2 weeks,
Oh,
at least
okay.
2 weeks.
So
by
something
then. So I don't know exactly what that date would be, something like August 3rd or 4th, maybe.
Okay.
So timeline wise, the plan is, because the report's due in September, the August board meeting, which is like August 17th, I think, will be our last opportunity to approve the final version of the report. So our August meeting is when the plan is that we will take a vote and say we approve this report and agree to submit it to the legislature. So at that meeting and after that meeting, there won't be any more opportunity to edit. So in order to be ready for the August meeting, Lee, would you say you need 2 weeks before that August board meeting to have all the final edits on like draft 4 submitted? It would help to have like a ultimate due date for any edits, because
I think the
that's
very
August.
latest date would be,
16th.
We'll say-
20th.
yeah, we'll say August 10th, because I think 10 days, that way I can focus on getting those edits, and it can be posted a week in advance.
Okay.
Okay,
Good.
yeah, so our meeting is August 20th, and so August 10th will be the final time to submit any edits. I would also encourage all of you to really look specifically at any sections that pertain to the committee that you were on, and make sure that what's written in the report accurately captures the discussions that were had at the committees, to make sure that work is part of our report. Great. Any other questions for Mimi about the executive director? Oh, sorry, Mike, go ahead.
Well, a couple of comments. One is, of course, all of us are excited about Bruce's process of reentry, as well as hearing from Bruce later. I particularly delighted that Bruce is coming back. I really appreciate the opportunity to review both California and Washington stuff. Unfortunately, I went into the weeds, Mimi, on that. I've read every footnote. And it's just, it's remarkable how much staff is digesting. So I think that's important. I'd like to maybe stress from all of that to what's the big point, and that is this is clearly an iterative process. It's going to continue to be an iterative process, that whatever we decide today or 2 weeks from now is still going to be preliminary. And I hope that's an important message, that people don't think that this is so cast in stone that nothing else could be changed, that it should be preliminary. And again, thanks staff for an incredible amount of work you're doing. It's unbelievable what you're able to make happen. So thank you.
Thanks, Mike. Any other questions for Mimi or Lee about those items? Okay, great. We will move on to the CECC update. I'll pass it to Michelle and Amy.
Hi, yeah, this is Amy Fellows, co-chair of the Community Engagement Communications Committee. So at our June 24th meeting, we had a special guest, Warren George, sharing his presentation of the Elway Research Poll on Oregon Universal Care, which was a 2019 random survey of Oregon voters. It was well received by KEC members who had lots of questions and a robust conversation. If board members are not already familiar with this poll or need a refresher, we strongly encourage you to watch the recording of the June 24th Community Engagement and Communications Committee meeting. We submitted a June public comment summary from KEC, which included 2 written comments from Angela Hale and Jackie Naganuma, and 1 in-person comment by Lou Siniger. Jackie's comment requested a plain language summary of the current plan that will be going to the legislature in our report, which Lee is already working on. And Lou expressed appreciation of Warren's presentation and shared some reflections on it. We are eager to hear who the governor will appoint in September for our 2 public engagement board seats. And our July 22nd KEC meeting, we will share the report from the Deaf and Hard of Hearing focus group, and we'll hear from the public. So anyone who wants to share comments can register on our website, and public comments begin at 5 p.m. And remember, at these meetings, you're allowed 5 whole minutes. That's all I have. Michelle, do you have any additions?
Great, thank you. Thank you, Amy and Michelle, appreciate it. Okay, next up is Bruce to talk about the Medicaid Advisory Work Group.
Thanks, Helen. Greetings, everybody. Glad to be back. I'm just going to really go through things pretty quickly. It's a lot of work that's been done over the last 6 months. This is really about the effects of HR 1, the federal bill on Oregon's Medicaid system, which are going to be pretty profound. HR 1, it's a huge bill that really looked at tax policy, military spending, a variety of things, but has some real specific impacts on Medicaid and the Oregon Health Plan. Just to give you some grounding, I want you to remember 4 numbers. One is that about 1.4 million Oregonians rely on the Oregon Health Plan. That's about 1 in 3. 57% of kids in the state get their care through the Oregon Health Plan. Because of HR 1, we're estimating that about 200,000 low-income adults are going to lose Medicaid coverage, and that over the next several years that the state will lose about 9.4 billion, that's billion with a B, dollars in state and federal funds by 2031. So huge impact. Because of that, the governor established an advisory group on Medicaid sustainability to develop an understanding of HR 1 and its impacts, and to accelerate planning and actually to give the governor advice as she puts together her governor's recommended budget, how to mitigate some of the effects of this. HR 1 at the highest level does two big things. One, it really affects coverage in the health plan. It establishes new work or community engagement requirements for some adults on the Oregon Health Plan and more frequent eligibility checks, moving from eligibility every 2 years to now eligibility every 6 months. Because of that, it's estimated that about 200,000 adults will lose coverage at some point because either they fail to meet a deadline, they fill a report out incorrectly, they don't have the appropriate information, they're not meeting work or community engagement requirements, a whole host of issues. And then there's also some federal funding cuts that are primarily due to changes in how we fund the Oregon Health Plan, changes to provider taxes, state-directed payments, etc. The bottom line and what the group was dealing with is that there's about a $420 million general fund budget hole out into the 27-29 budget that needs to be filled. And so the group was really charged with coming up with some recommendations for how to fill that $421 million general fund budget hole. The group met about every 2 weeks. We looked at and established some guiding principles, did a thorough review of Oregon Health Plan funding, history, where and how care is being delivered, administrative issues, looked at looked at um, cost drivers, a whole variety of ways that really spent a lot of time looking at, the Medicaid landscape, enrollment trends, financing mechanisms, spending patterns, utilization, et cetera. And, with that, the group began to discuss a variety of options to fill that $421 million budget hole. The report is online. There's a lot of information. In summary, the group came up with recommendations across, well, I wouldn't say recommendations, they were options, 46 different options for the governor to consider. And they span about 6 different categories. One was changes to CCO structure, looking at things like consolidating CCOs, consolidating non-emergent medical transportation funding, et cetera. Looked at a variety of clinical efficiency and utilization issues, places where we as a state utilize healthcare at a greater rate than other states do and don't get any value from that. So really looking at where we could make some changes in utilization, some provider rate changes. There are places within the Oregon Health Plan payment system where some groups are being paid disproportionately more than others. There's a whole host of pharmacy recommendations around a single preferred drug list and a single PBM. There are some benefit changes looking at optional benefits to the health plan and where those could be reduced or discontinued. And then lastly, some, across the board budget issues. In other words, rather than having 5, 6, 7, 8, 9, 10 different uh, different ways to fill the budget hole. This would be a 2 or 3 or 4% across the board, just simply a budget reduction rather than all the other ways that we were looking at things because of the ability to administer those. So I would encourage everybody to, look at that. Sorry about that. I'd encourage everybody to look at the report. It's, there's a lot of information there, outlines the 46 different options. Just some sort of key takeaways from the group that, I would highlight is that there's a preference for looking at administrative efficiencies before any kind of rate or benefit cuts. The other issue I would just highlight is in putting together the principles, two key principles were not reducing coverage, so there aren't any options that reduce people from the Oregon Health Plan. And the other main issue was to maintain access. Because if you maintain coverage but don't have access to care, that's vacant coverage. So the group had a preference for looking at administrative efficiencies and utilization issues before benefit cuts, a preference for having there be a strong clinical review of the optional benefits, a preference for maintaining adult dental services. And then the last comment I would make before talking about next steps is that the $421 million budget hole in 27-29 grows to over $800 million in 29-31. So what are the next steps? The advisory group has delivered their plan to Governor Kotek. She'll review it. She's certainly not obligated to take any of those. What she's going to do is continue to take input from people around the state. The budget figures and needs will change. There's going to be another caseload forecast and statewide revenue forecast, so there'll be more information. Based on all of that, the governor will put together her governor's recommended budget, which by statute needs to be submitted on December 1. There'll then be a legislative session where the health plan budget will be considered. And then finally, there'll be a legislative adopted budget, which will be the final budget, which will happen at the end of the legislative session. So this is the start. It provides a skeleton of potential options. Other folks may have some other and better ideas that I'm sure both the governor and the legislature will consider. I would, take a look at the report and I'll stop there.
Thank you, Bruce. That was great. Couple questions. Go ahead, Judy.
Thank you. Thank you, Dr. Goldberg, for your work and to the committee on this hard work. There are several of those 46 options in the buffet that you've offered to the Office of the Governor that are very much in alignment with our work. In fact, we would call them stepping stones towards a universal health plan. Would it be helpful for this body to make a letter or a statement to the chair to write to the governor's office and say these 4 things are elements that we strongly encourage or endorse adoption because they align with the work of the Universal Health Plan? Or is that decision making separate and isolated from those kinds of things?
Well, I think my sense is the governor would appreciate any sort of input from, anybody, from the public in general, from different organizations. And I think, if we as a group have some strong feelings about that, we can and should provide that input. I think it would be appreciated.
Great. Any other questions for Bruce or comments? Go ahead, Shanwei.
Thank you, Bruce, for a very helpful summary of the impact. I just have a more wide general question, like to pick your brain. Given the scenario you just presented and you have worked on for the last 6 months, can you kind of summarize what will be the impact in terms of cost and finance for the Universal Health Plan?
Oh, great question. I think that the biggest impact on the Universal Health Plan work would be a decrease in federal support for Medicaid. That I think as our planning has indicated, we're relying on, and, you know, correct me if I'm wrong, we're relying on the federal Medicaid funding as well as Medicare funding. And what HR 1 does is it will reduce some of the federal Medicaid funding that we currently get. So I think it will have a financial effect on our work. And, you know, I think the question is one of timing and when and if there'll be changes federally with a new administration, et cetera.
Thanks, Mike.
Thanks, and thanks for those two questions. I've got kind of a third question, Bruce, for us. It appears to me that if we're trying to eventually normalize rates and the like, one of the things that I have seen over my many years here is that by us being efficient in Medicare, it's had the cumulative effect of we do not get adequate Medicare reimbursement. So I think actually one of the strategic things that occurs is not due to Medicaid, but the fact that as we migrate to universal health, the state also has to come up with a new strategy for how to more fully capture Medicare. And I know this might seem like it's off the topic. Actually, it's not, because the solution for revenue is not just how we live within these federal Medicaid cuts, but how we get money that other states are getting that we are not currently by Medicare. I wonder if your group had considered that or not.
Well, the short answer is no, the group didn't consider it. We were not, and we weren't charged with looking at additional revenue. You know, having said that, on a personal note, Mike, I totally agree that you know, we have a higher hill to climb as a state because of the fact that, you know, our Medicare reimbursement is below that of a lot of other states in the country. And so therefore, if we're going to normalize rates and we're going to bring up Medicare and Medicaid rates and normalize those, that we've got a lot of work to do and a significant issue. And I would agree with you. That's something that we should be advocating for as we move forward.
Thank you.
Any other questions for Bruce? Mary Lou?
I guess, Judy didn't identify which four you're thinking of. But wondering too, Bruce, if you have any, recommendations on kind of your list of 4 or 5 things that you think, from your report that would be helpful for us to make sure that we're considering as possible stepping stones.
Well, you know, to me, I think the biggest one that jumps out is, you know, how we can do a better job at pharmacy spend and how we can aggregate purchasing in a way that lowers pharmaceutical costs. So that'd probably be, you know, number one. You know, the other piece is there's a lot of talk about, you know, administrative simplification. And I think certainly part of what we've been working on as a universal healthcare board is looking at how to create a system that is much easier to use and really reduces the administrative burden of healthcare. So those would be the 2 biggies that I would throw out there, just off the top of my head.
Anyone else?
Just one final thought there, kind of bringing a couple of these topics together. So Mary Lou and I had a lunch with Jill Arena, and as you all know, the HCAO has sponsored a effort separate from us on what really is the potential for savings, and is it as much as Bill Shaw was saying? Is it as little as some others may have said? And I'm the meta message I got from Jill Arena yesterday was they're conservatively optimistic that yes, they're beginning to identify enough things that enough provider clients of them are thinking about there are ways for us to get there. So I wanted to balance the somber note we all feel regarding these Medicaid cuts with maybe by us pushing forward with a universal health plan that actually is a major piece of the solution if we think boldly enough.
Yeah, thanks, Mike. I just wanted to make a final comment too, that the changes related to HR1 in terms of enrollment in Medicaid and the financing were anticipated and incorporated by our Milliman consultants. And so when they were projecting out numbers and expenditures for 2032, they did consider the likely impacts of HR1 in those numbers. So that has been pulled in there as well. Go ahead, John Wayne.
Just have a quick question. You mentioned your number one strategy is to bring down the pharmaceutical costs. And also you mentioned about one of the strategies to create a preferred drug list. I'm wondering whether this both for the universal health plan as well for Medicaid, whether Medicaid has been considering developing a formulary. Most countries with universal health care has a formulary. That's what we call preferred drugs. So have you considered that?
Yes, that's actually the single preferred drug list is exactly that. Whether you call it a single preferred drug list or a formulary, that's exactly what it is.
Great. Thank you so much, Bruce, for that report. And as fellow Oregonians, thank you so much for your service on that group. I know we all appreciate that, as well as your service here on the board. Thanks for that. Okay, moving on, we're gonna transition to Morgan Shook, who's going to talk to us about the Legislative Revenue Office information and economic impacts. I'll turn it over.
Great. Thank you very much, everyone. Here, let me just start sharing again. And I want to say thank you. It's good to see everyone. Okay. Can you see my screen? Just double checking.
Yes.
Great. So just to level set and pick up the conversation, you've had subsequent or previous conversations taking the recommendation of the revenue plan from Finance and Revenue and have made some adjustments to that with respect to some of those elements. During that time, we have been coordinating with the Legislative Revenue Office here to help do a couple things. One, to provide some additional sort of calibration to how they do their work with the state legislature to provide revenue estimates, and because they have tools and greater access to precision of data beyond what the Finance and Revenue was working with, and can provide some value add comments on making sure we specify it sort of correctly to both a little bit to state law, but also to sort of how the tax may be sort of administrated. And so this presentation here is really that level set to sort of do that and then bring it forward to what we expect the plan costs to be in 2032 with respect to what we've been calling the revenue replacement target. So just for folks tracking along, there is quite a bit of spending today. I think this is that is going into the plan through out of pocket, through employer sponsored insurance, through individuals. And the idea here is a lot of that spending, right, is reconstituted through transferring of Medicaid, Medicare payments, spending that's already in the system, but those out of pocket personal and employer payments for healthcare are reconstituted as part of a tax plan. And that tax plan is meant to be progressive by design. And what you see here today is to sort of bring all that forward in 2032. For folks too, I think it's worth noting here, and I think to anyone who's been tracking here, the conceptual tax plan that we've been working with, right, for that revenue replacement has really been trying to sort of triangulate between adequacy, right? Can we raise enough revenue relative to what we've been trying to do? Can we deal with those economic impacts? So I hear things like equity, behavior, how it changes economic competitiveness. We've been dealing with some of that in more informal terms, right? But very much of those and
It's starting to cut out a
this
little bit.
oh, sorry, this image here is really about can you hear me?
Yes.
No.
Oh, okay, sorry. But it's worth here noting that there are sort of big challenges ahead still with respect to making sure whatever comes out, right, conforms legally to the administration of it. And I think we've had meetings with both LRO and with Department of Revenue, making sure that, there are elements of sort of the employer tax plan and other things here that we just need to make sure as they move forward, right, can be sort of administrated appropriately and still then meet the needs of the things that we've been talking about with adequacy impacts and the policy environment. So this is just just make sure we kind of level set around that. And so what have we done here? So we've done first we had to sort of refine or sorry, not I said refine, and we've been able to do that through a process, me and early to look at the
Morgan,
minimum estimate and yes.
you're starting to cut out quite a bit. Do you want to try ending your video feed?
Yeah,
So
maybe that'll help.
okay.
All right. Okay, hopefully that's a little better.
Yes.
Okay. And so we've gone through a process here to sort of bring that forward to 2032. I'll kind of quickly cover that. And then just tidy up some elements of the actual tax plan from FNR's work and the board's subsequent discussion and voting. So just conceptually what we did here, and we provided some range of scenarios. The first one here is we started with 32 UHP expenditures from Milliman. We provided some best level sort of judgment, professional judgment around potential provider administrative savings, improved collectability. We also wanted to make sure we understood sort of payer administrative costs to get to what we think is maybe a level of what the plan potentially could be. And so we have then deducted existing federal state funding that would be transferred into the plan to come up with our best revenue replacement target. So this is think of it as a number we're trying to sort of then think about reconstituting as a tax plan, replacing the existing employer and employee spending that happens. Okay, and when we do that, we have kind of what we call our best estimate, but then we wanted to make sure we kind of provided some thinking, and I think that reflects conversation in this group here that potentially the UHP offers some additional upside around potentially lower cost savings through additional administrative costs and or ability to sort of reduce prescription drug costs through better negotiation. And so what we have is kind of a sort of lower cost scenario and an enhanced savings scenario to give us kind of a range of between 30 and $36 billion as part of our 2032 revenue replacement target. And when we try to think about the tax tools that have been used, what we see here is really just some good understanding of kind of where those dollars net of tax credits are coming from, right? So a large portion through the employer tax, payroll tax, which is not surprising since most individuals are receiving health care through their employers. And then much of the out-of-pocket and individual contributions being reconstituted through a healthcare personal income tax, with additional amounts coming from both the corporate income tax, corporate activity tax, as well as the lodging tax. What you see here then is just some comparison of how then we think about getting to those things, right? And so in the row there in 2022, it's the estimated contributions that were coming from the estimate from the Finance and Revenue Committee. I'm sorry, I'm looking at, I don't know why there's a typo in not having the healthcare personal income tax, but you can see we then translated those pieces into kind of our low, medium, and best case estimate. And what you see there is a breakdown of the revenue that would be needed in 2032 by those tax tools. And this is the way LRO then back solved for the rates that would need to be in place to raise this amount of revenue per those tax tools. And so they are using their forecast tools. And just so you know, right, the forecast changes every time they update it and have a better understanding of what's happening in the, or potentially what might be happening in the Oregon economy in 2032. And so take sort of the rates on the next slide, with knowing that level of fluidity. And so if we're trying to raise that amount of revenue.
Morgan, can I interrupt you for a second? Can you go back to your previous slide?
Sure.
Yeah, so just I want to pause here, make sure everyone gets that, because I think this is a really crucial point, that what we've given LRO is the instruments that we want to use and the proportion of the revenue replacement target that we would like each of those instruments to cover. And that's noted under the share portion. So we want, whatever we need to raise to pay for this, we want 51.5% of it to come from an employer payroll tax. And then we're asking, so therefore, what is the employer payroll tax rate actually need to be? We've been floating around some numbers of what those rates would be, but that was based on previous estimates of an old revenue replacement target. This is the updated version of that. What has not changed is the share of the revenue replacement target from each of these instruments. But what has changed is how that translates into actual tax rates, because the dollar number has changed based on our updated expenditures. I just want to make sure everyone's clear about that before we go into that. Go ahead, Mary Lou.
I saw that on the previous slide too. Why does the lodging tax have a negative in front of it?
It's not a negative.
Approximately.
It's a tilde that means approximate.
Oh,
It's not a negative, but I was like, same thing, we can't see.
because I'm going, how did it give me a negative? Thank you.
Okay, it's approximate.
Thank you.
Yeah, we're gonna give all tourists a credit.
I see it
Mary
now
Lou.
if I'm really looking. Okay,
Yeah,
thank you.
sorry about, thank you, Chair Belanca, for that very concise summary of what I'm about to show you. And so when we then look at sort of moving the work that the Finance and Revenue did by calibrating in 2022, and noting one of the big differences here is we probably have a much larger revenue replacement target than, even if we were adjusted for inflation, that Finance and Revenue is working for. So they are sort of just, aggregately probably a little bit more. Like if we were just to roll forward the 16.9 billion that we were working with there, that would be about 26 billion. So we're seeing here, when we calibrate it to the Milliman estimates, right, our low is about 30 and our high is about 35. And so what's the impact on rates? And so you can just have a comparison between our low, mid, high relative to the rate that we've been working with in from the Finance and Revenue to understand how we get to that revenue replacement target.
So Mike has a question, go ahead.
So Morgan, I'm still trying to follow you here, that this for 2032, and again, I'm not a member of that Finance and Revenue, so my question is probably very elementary here. So the target was 26 billion, and now the lowest possibility is 30 billion. And I guess what I was saying before, to the extent to which we can make some hard decisions, based on reasonable projections about reducing our cost structure. And as we transition from now into the steady state, based again on my conversation with Jill Arena yesterday, if we structured additional savings that again, Bill Shaw and others are saying, I believe we can at least be looking at something that maybe isn't 26 billion, but which is closer there. My second comment is, rather than staying on this kind of artificial, oh, we came up with a calculation of 43% of this and 50, etc. I'd say we incorporate some of the thinking that Cheryl gave us last time. Is we really need more engagement with the public. I mean, why 43%? Why not 30% from that? So just I just want us to stay flexible, and as we iterate with this stuff, we begin to more deeply understand the ramifications of what we're doing here, so we come up with a realistic and doable plan.
Yeah, so Mike, these are really good comments. Let me just respond a couple of times here to, I think, to help clarify. So the difference here, when Finance and Revenue was working with it, it didn't have the benefit of all the Milliman estimates on the expenditure. We were working off of the joint task force work, right? And we always knew we needed to calibrate. So this process here was really then to calibrate to a UHP cost that was defined by Milliman, that then we could then back solve for what we think the revenue replacement target was going to be. So I think part of it's not like all of a sudden the cost grew. We were just working off of a number that we had to kind of size the tax rates. And so your comment about the tax rates, the reason the tax rates are the way they are, I think, and I don't know if Charlie or Richard there, but it was really then to try to keep the level of spending by groups as much as possible, so that we weren't trying to sort of disturb kind of the nature of the payments coming from businesses versus households for the most part. Obviously, the tax plan sort of shifts the sort of relative burden of that amongst individuals, but at least from a sort of contributions, they weren't sort of arbitrary. Let's just pick 43, 53 in terms of the tax types. They really were sort of drawn out by understanding kind of where those current contributions are coming from and trying to reconstitute in a way that wasn't going to be sort of, create sort of, big disturbances in how those individuals or entities were paying.
I understand that, but stay with me here. If we could identify another, and let's say $5 billion in savings, then would you keep the same percentages, or do you have the ability to maybe move the healthcare personal income tax to a lower range or not? I did you all discuss that?
Oh, I don't. Yeah.
Sorry,
Yeah, I
Morgan,
don't disagree with that part. I just want to make sure that why the percentages were they were. Yep.
Yeah.
Oh yeah,
So
Mike, I don't disagree with your point there. I was just mostly just saying there's a reason the rates were the percentages were the way they were.
Thank you.
right, and I'll just point out that is the topic of our discussion today. That's what we reserved 2 hours for, is to talk about how we want to proceed with this
jumped the
plan.
gun.
So, yep, but you set us up for that discussion, but yeah, so to recap, the reason why these proportions of revenue are that way is to, as much as possible, mimic what's currently happening in terms of who's paying what, employers versus households. And yes, to also reiterate what Morgan was saying, these numbers, we believe, are far more accurate than the numbers that the task force was using from the Optimist report. It's a much deeper dive into actual expenditures. I'll remind everyone that the Optimist report was also before the pandemic, and healthcare expenditures changed enormously during and after the pandemic. So these numbers are the more accurate numbers. The 35.5 is a really good guess. And then the 31, and then the 30.2, 31.9, and then the 30.2 are our estimates at like those, exactly what you were saying, Mike. There's probably more there than we accounted for in Milliman, which is the 35.5. And so that's how we came up with those two numbers. So everything you've been saying is represented here. This is probably as low as we can feasibly go based on the best evidence that we have. So these are the numbers that I'm going to ask the board to just work with for now. You're absolutely right. There are lots of other potential avenues we can go down. But for the purposes of sort of our revenue strategy and completing our work for the legislature for September, these are the expenditure numbers we're trying to work with. This is what we've solved for in terms of our revenue replacement target plan.
Thank you, that's helpful.
Okay,
Bruce has his hand up.
sorry, go ahead, Bruce.
Yeah, thanks. And, you know, I've been trying to catch up. So my apologies. And this may not be the right part of the meeting to raise a couple questions so far. One is, on that previous slide, you had the change in admin from 6% to 3%. Can you just, what is that? What was cut going from 6% to 3%? I mean, how was that just a finger in the wind to go from 6 to 3, or what was being done at 6 that isn't being done at 3? Can just a sense of how what that was all about would really be helpful to me.
Yeah, do you want to take that one?
I'll take that one. Hi, Bruce, this is Mimi. So I think that's it's an excellent point, and a lot of it had to do with the estimates provided for administrative costs that are related, for example, to Medicare fee for service. So that, 6% going down to 3%, there's been a significant amount of pressure from I would say from board members to make sure that in our estimates that all potential improvements in administrative costs are taken into account. Milliman, their best estimate was of a 6% administrative cost, and then based on a lot of literature review, and then again, based on people's estimates from what's happening in other countries, and then specifically though, the Medicare fee for service and some Medicaid fee for service, which is more like 1.5% or 2%. That's where 3% came from. So it is, as Morgan said, these are the numbers that we have for now that we are using. But things can certainly be discussed further, but the decision had to be made at some point to use that as an estimate. So I hope that answers your question.
It
Yeah,
does. Just to be clear, it's not based on any sort of a business plan. We didn't cut administrative staff, or we don't
Correct.
that 3%. We don't know whether it's too much or not enough.
I would I agree with that sentiment. It is based on sort of literature review and other models. So it's definitely not based on a built out business plan.
Okay, so well, we could talk about that later. That's kind of concerning. If we're going to bring a plan publicly, we should maybe have a little bit more detail into what the administrative dollars will go for. My second question, and again, it may not be the right time, is that the corporate tax piece. How much do corporations pay for healthcare today? How does this tax sync with that? Are they going to be taxed more? Will they be taxed less? I know every business does things differently, but do we have some background into what's going to happen?
And so Bruce, a follow-up question. When you say the corporate taxes, and I'm looking here, are you talking about the corporate income tax, corporate activity taxes? Because
Yes.
yeah, okay, so I don't know how much of
Can't hear you, Morgan. Morgan, can you repeat that?
Sorry.
Morgan, so I can jump in. Yeah, go ahead, Morgan.
Yeah. Oh, sorry. We've got thunderstorms rolling over our area right now, so I don't know why my internet's all gone wonky here. So the corporate income tax, corporate activity tax is just additional business contributions as the Finance and Revenue Committee designed it. From the employer payroll, right? That really meant to kind of mimic
They're paying now.
a
maybe someone else could answer. I'm just real
Yeah,
simply, I want to know
yeah.
when you put together the payroll tax, the income tax, the corporate activity tax, if I'm a business, am I going to be paying less under this plan or more?
So Bruce, it's a little bit hard because businesses are a little bit all over the map and it depends on if they're currently covering insurance for their employees or not. But roughly speaking, the employer payroll tax is meant to mimic what they're already paying. So we think that's about a break even. The CAT and the CIT are increases over what they're currently paying. The estimate is that if you are currently covering your employees with health insurance, that the majority of businesses will pay less under this plan. In actual absolute dollars, it'll be less, but also they are, it'll be eliminating the HR function of securing health insurance for your employees and enrolling your own employees. That whole administrative piece that employers currently have to do in their benefit plan, it would also remove that. So we think they will, in absolute dollars, pay less, but then also have the savings of that HR function. For most businesses, we can't really comment on large businesses. We don't really know what they spend or how that will impact them, the self-employed businesses. But for most other businesses, this will be a savings and an improvement. That's also true for households, that the majority of households will end up paying less under this plan than they would under current plans. There are like the top earners and the top businesses will probably pay a little bit more, but the majority will pay less.
I think we need to be careful, and you just said two things. You said the majority of businesses, but then you said it doesn't include those who self-insure. And a lot of our businesses self-insure. So
Well, my intention there was, Bruce, is that I can't comment on whether or not self-insured businesses will have an improvement or not, because we don't know what they spend. So we don't know if that'll be an improvement for them or not. So I can't comment on that. But for those who we know how much they spend, then it would be an improvement.
my comment would be, and we can continue, I think it's important to sort of know the impact that these taxes will have on our businesses and have some good documentation of what that'll be.
Yes.
I wasn't on the revenue committee back when those first, the corporate income tax and the CAT were discussed and decided on. Cheryl was, I don't know what the rationale, I understand clearly what you're talking about with the EPT. And trying to make it about the same as in collective and aggregate that businesses are paying. But I don't know, was it just more like corporations should be paying more? I don't.
Yeah, I recall it to be a best estimate. We had like this calculator thing that Charlie and Richard built, and we were just like increasing one, decreasing another. I mean, and trying to be, as Helen said, not so much trying to align the percentages with what they are now. But yeah, we did want to raise the corporate portion a little bit, but I can't tell you more than that. I just remember that.
And Chair, if I could ask, we also, if this is appropriate, we have Richard Gibson and Charlie Swanson are also available members of the Finance and Revenue Committee, just at this point, if they have things that they would like to add to help the conversation along.
Okay. And then just getting back to Bruce's earlier comment, those additional savings numbers, so that best estimate number that Morgan was showing, about 35.5, I would really encourage the board to think of that as our number, because that reduction of administrative costs from 6 to 3, as Mimi said, is aspirational. It's potential, it's theoretical, right? And when we're dealing with numbers this big and a plan that would affect every aspect of Oregon's economy, I think it would be prudent to think more on the conservative side, at least in the beginning, and with the potential that more savings could be realized down the road. But I think we should err on the side of being conservative, because these are numbers we can't know, and there are lots of potential theoretical savings. But if we plan for those savings and they don't materialize, we are very quickly in the hole in the first year or two. So that would be my comment on that. Go ahead,
I
Cheryl.
just wanted to clarify one thing about the administrative costs from what I saw on the slide. We're just talking about the payer admin costs, not the provider admin costs, right?
No, we're talking.
I thought I saw it said payer.
Well, in those, so we had this discussion a couple board meetings ago, in those adjusted numbers, we did incorporate provider savings in that, with the caveat that those are rates that would need to be negotiated. You'd have to renegotiate rates with providers in order to find those savings, in order to realize those savings. And
That maybe could be clearer then, because it looked to me that it only included payer, but I also can't read it very well,
Yeah.
so, I don't know, yeah. That's a big issue.
go ahead, Mary.
One of the things, Bruce, I guess my reaction back on the administrative savings, some of us have continued to debate and argue that the Milliman report on the plan side had a very large administrative cost with thousands of employees. And that has been discussed and debated and brought down, in my mind, to a more reasonable level. I think that in my mind, and I think that Dr. Chi, I mean, others can speak to this, that Milliman in some ways was creating another big insurance company based on kind of what insurance companies do and how they do it. And we're talking about a transformational universal health plan that has not some of the things they put in there, we have been debated about whether that would not be included. And so I think some of that savings idea came from cutting back on that, the plan's administrative costs. And later and updated IT things. So, yeah, okay, that's all.
Okay, go ahead, John.
Just have a quick example how, what are the item the board discussed, want to reduce the initial estimation of administrative costs. 3 specific items that was listed in the cost estimation of administration that we have big question. One, Mary Lou mentioned, in the minimum report, they estimated Oregon will need 15,000 full-time employee to administer this universal health care. And I quickly pull out Taiwan with 5.5 times the population. The whole nation only employs 3,000 full-time employee to administer universal health care. So we use that as a reference point. And 2 more items. One is marketing. Once we implemented that, we don't need marketing costs. And the other item is patient utilization management. And the insurance company spent a lot of resources in managing actually to discourage patient utilization. And we don't need that. So these are the 3 obvious items among others that bring up the discussion of we need to further cut down the administrative cost estimation.
Generally, that's great. Thanks. I guess my comment to that would be maybe 3% is too high.
Yes.
Yeah.
I mean, the issue is what are the numbers based on? Not is it too high, too low, et cetera, but to actually have an accurate sense of what we're paying for with that.
Yeah, so we've had pretty robust discussions over a number of board meetings around the expenditures portion, including very thorough discussions about administrative costs and where those numbers came from. I'd really like us to focus today on our revenue strategy. I'm going to remind the board that our goal today is to approve a revenue strategy. And the actual percentage numbers of what those taxes would look like are based on our current best estimates of those expenditures. But those proportions of, which instrument they're drawing from are going to stay the same. And our goal today is really to focus on the revenue strategy. As I think it was Mike, forgive me, who said at the beginning of our meeting, this is not an endpoint. This board is not sunsetting. We have to get this report in September, but then we have time to reconsider a lot of this work. We have time to, look at what the impact on businesses would be and to talk to businesses. We have time to put this in front of the general public and get feedback on this. But really what we would like to focus on today is looking at these numbers, and I'm going to ask the board to focus on the middle column on this slide, which is some savings above our most conservative estimates, coming up with a total revenue replacement target of $31.9 billion. And that the tax rates that would entail are listed there in that middle column, specifically an employer payroll tax of 10.44% and a healthcare personal income tax of 14.3%. Now, especially with the healthcare personal income tax, I'm going to remind people that is not the rate that anybody will pay. Because we are excluding the first 200% of FPL of income, that will be the rate that people approach as their incomes rise. But I want to show it if we can. So first, before I do that, Morgan, is there anything else you wanted to say about this slide before we move
Yeah,
on?
sorry, I'm hotspot on my phone. Looks like finally the internet dropped out here.
Okay.
Apologies, everyone. Of course it happens exactly as I need to present. So yeah, I think just to reiterate what Chair Blanca said here, the reason we were trying to sort of, you know, implement some of these potential cost savings because of the conversation, but I think also to give this board a sense of the elasticity on the revenues and the rates by tool, so you can understand, like, well, if we're trying to raise $3 billion less, what is the impact on those rates? The second point is on Chair Blanca's point, particularly with the healthcare personal income tax, right? That is the headline rate, but individual sort of net effective tax rates are much lower. I think if you recall from the work in the finance and revenue piece, the way we were looking at it, many households making less than $70,000 were effectively paying no tax because of the FPL issue and the healthcare the EPT tax credit that was coming back to them. But that rate would rise significantly for higher income households to a much, obviously, to closer to approximating that headline rate that's there. So just to keep that in mind.
I
Thanks,
guess I
Morgan.
just want to tell people to take a look at what Charlie said. He did respond about how that CAT and CIT.
Right, so Charlie put a comment in the chat that says that Finance and Revenue Committee estimated that the sum of the EPT on private businesses plus the CAT and CIT would be about the same as, but slightly less than what private employers pay for employer-sponsored health insurance in the status quo. And again, with the additional savings of not having the HR burden of securing those benefits. Okay, any other questions for Morgan on this? Go ahead, Mike.
So Morgan, if we, I tend to agree with Helen's thinking here that we need a target, and we need to say, we believe it's conservative, and we also need to say, and if we can systematically, by further developing this into an actual real business plan, we get to a target that's less than 30 billion. We can use that money for building up reserves and transition. And the other point is that, remember, this is based on a fully, predominant single payer, but there's going to be various steps along the way to get to that in the transition. So, I mean, I think, Morgan, what you're saying, I think that's reasonable, recognizing there really is more potential, but until we can effectively, I think we can say that in the report that there's some other things that we'll be working on, and at the same time say that this is preliminary, but you need a target. And I think what you're presenting, I think you're directionally correct without quibbling on some of the how much more billions in savings or adjustments we can do. We still have levers even after agreeing on a report that we should be developing and looking at this fall and next year, and that I'm sure others will be looking at as well.
I concur with that comment, Mike. I'll just add to, I meant to say LRO is also, based on your conversation that you're about to have, can be responsive to sort of making some of those potential changes for you to see.
Thank you.
Michelle?
Thank you, Chair. And thank you, Morgan, for this work. I understand the need for these numbers, especially as we coordinate with LFO and other entities that are, doing calculations for us. I do think it's an incredibly unhelpful slide for any public facing documents, including this meeting. And I just wonder if there's a way that we can better contextualize what we mean by this. I think having printed materials that say that the effective or that the healthcare personal income tax in 2032 is going to be 14.3%. And then we have all these asterisks and notes that aren't on the slide that say like, well, actually, but most people won't pay that. And, I think that's super dangerous. And you all know that I'm really coming from a community engagement and communications perspective. And I think that is the moment that we are in. Like we are in that phase of work. We're past the phase where we can do quiet work in the background, and we're in a public facing phase, whether we like it or not, and whether we recognize it or not. And we're at a phase where I think increasingly media is going to be watching our meetings. And anyone who has started to take this more seriously, like the industry group that was put together by health insurance companies earlier this year, I would encourage the board to contextualize any numbers that we are putting out. And if there are asterisks, that we put them on the slide, in the report, in the printed material every single time, just to protect this work.
Morgan, in response to that, do you want to give a quick update on the calculator?
Yeah, so we are tracking along with this process to build as part of the public outreach and communications, to build that calculator so that individuals can actually enter in their own information, or typical kind of information, if they don't have it at hands, to actually understand sort of their pre-post sort of payments for healthcare. So they can do two things. One, understand that there's a lot of money they're already spending, or their employers are spending money for their healthcare, and that will change going forward depending on their unique economic circumstances.
And do you have a sense of when that might be ready?
We are timing out. I'll ask Mimi there, but we're timing that to be part of the public communications part of the piece. I don't have an update on sort of the exact timing.
Okay. Bruce, I see your hand.
Yeah, I just want to echo what Michelle said. I think there's a lot of work that needs to be done to really frame all of this and have it be in a way people can understand. I'm getting back into it, and quite frankly, all the numbers, all the slides, all of everything is hard for me to follow, and I would imagine, quite frankly, it'd be really difficult for the general public. I mean, to me, my big question is, does our plan save money or not? Is it going to cost people more or less? And I don't know that we have a clear statement about that. And I just think we need to pay some time and attention to how a lot of this information will be consumed. So thanks, Michelle, for raising that.
So we don't have a clear statement right now for the general public, because our first job is to decide on what our plan is. And so if we can get this board today to agree that this is our plan, then we will work for next steps to then translate it into a way that everyone can understand. So just to draw us back, like, we have to at some point have a vote, possibly today, hopefully today, that we're agreeing that this is our revenue strategy. And once we have that endorsement by this board, then we will put all our efforts into clarifying what that means for the public and spelling it out in terms that multiple interested parties can understand. But if we can stay on that task, I think we will get there then. But yes, communication will be the next step once we decide what our plan is. So let's move to the next slide. I took a stab at this, and this is, so I used that middle number, oops. Oh, sorry.
Oh, did you want your slides to completely replace all of these?
No. Okay, no, go ahead. I'm gonna go ahead, Mimi, let's do this. Yeah, go ahead and do these slides quickly, and then we'll go to mine. Yeah.
Okay, I just wanted to ask Morgan if he had other things he wanted to add. I wasn't sure if he was done with his presentation.
Yeah.
No, all good there.
Okay.
All right, thank you very much, Morgan. I'm just checking on the time. Do you want to, still good to go forward with this?
Should we take a break? You want to take a break? Okay, all right, let's take a break now, and then when we come back, we'll start the discussion and hopefully a vote on the revenue plan. So it's about 10:25. We'll come back at 10:35. Thank you, Morgan.
Thanks.
Okay, great. Welcome back, everyone. We are reconvening. And we'll pick up our discussion where we left off. I'll turn it over to Mimi.
All right, thank you. That would be a big presentation. There we are. All right, so thank you, everyone. The purpose of these next few slides is really just to go over what we talked about at the special board meeting that was only 2 hours long. So some of this is recap, and I really wanted to try and capture all the observations that actually came from the group, from the board. As we were talking about revenue, as you all were talking about revenue replacement targets and levers. So just kind of to level set and to remind people of the things that have been being brought up, and then Chair Belenko will take it away after that. So first off, again, we have those revenue replacement targets that Morgan also presented and that we've spoken about. And they were observations from board members that revenue replacement target could be lower potentially because of lower costs for dental. There may be even further opportunities due to higher prescription drug savings. And that, of course, the expenditure estimate is dependent upon population rollout. So again, when we look at that revenue replacement target, that is for a fully formed, fully functioning, in operational universal health plan, which so just to keep that in mind. Next slide. Thank you. We did have a discussion about revenue plan tools. In other words, now that from LRO that the percentages, and that will be presented again, are available if there is a desire to change any of the way that the revenue plan is as it's currently written. So some of the potential changes could be to change the relative percentage contribution of revenue instruments. Again, so perhaps either increasing or decreasing the amount of contribution that comes from a personal income tax. Other revenue plan tools that could be changed to revise or to eliminate the employer payroll tax credit, to change the exemption levels on the employer payroll tax or the healthcare personal income tax. So that was what our commenter, Alex, I forgot your last name, at the top of the hour. Thank you, Polikoff, mentioned this morning. There's a potential for another revenue instrument. Again, another commenter said, such as a sales tax or a wealth tax. There is a potential to add tiers to the employer payroll tax or the healthcare personal income tax, and then also a consideration of cost sharing. So again, this is kind of the discussion that we had at our last meeting. Next slide, please. So when we look at those now, when we're talking about the expenditure tools, a way to reduce expenditures, some of the tools were to reduce the benefits that are available. And the other was not to completely reduce or change the population, but that it would be a phased in population eligibility. So not everyone would be eligible all at once. Again, observations that were given by board members to remember that those lever options, for example, around the employer payroll tax credit, they don't have to be either or, they can be considered a range. Or for example, dental doesn't have to be either or. You could have a more robust or less robust amount of dental coverage. And then this point came forward that for really to remember to reference the values and principles of the board, consider that community sense of governance and the importance of having statewide input. So and to really all of these are are decision points that perhaps are also very important to bring in front of the general public, the general population of Oregon. So certainly reasonable for board members to weigh in, but to remember that we haven't gotten all the feedback that is available. Next slide. Again, so now some specific observations and preferences. So again, these are just from the board members that they expressed. Cost sharing should be low on the list of options. And that phased implementation should be a prioritized strategy. The employer payroll tax credit could be lowered without being eliminated completely. There's a board member is concerned about removing the Medicare population, but open to phasing in the population with the eventuality of bringing in the entire population. And then again, benefits such as dental can be reduced without being eliminated. And there was a couple of board members did believe that they would like to consider wealth tax. Next slide. Oop, and I think, there we go. No, and I think that's it. And I'm going to turn it over to Chair Belanca.
So this is the revenue plan as it currently stands, that in the far left corner, it, you know, lists the elements of the revenue replacement target, all of the different ways that we would be getting revenue. And then there would be a range that, you know, the employer tax, payroll tax would vary between, I put my glasses on, I'm sorry.
9.9 to
9.89% and 11.62%, sort of depending on where the expenditures actually lie, that the healthcare personal income tax would fall somewhere between 13.5 and 15.9%, and the other taxes as listed there. This is the revenue plan that we are proposing submitting to the legislature. And to the point that was made earlier, that HCPIT is not the effective rate. If you go to the next slide, I think, yes, okay. So this is, again, this does not include the employer payroll tax credit. So this is just purely looking at what a 14.3% healthcare personal income tax would work out to as an effective rate. So far, the board has decided that anybody making 200% of the federal poverty level or less, which is that first column, $31,920, they don't pay any healthcare personal income tax. So that starts at zero. And then I put in the top one, roughly, if you're making the income of in those top columns, that is the effective tax rate that you would pay. So someone making $50,000 would effectively pay 5.2% in a healthcare personal income tax, because the first 31,920 are excluded from the tax. So the remaining amount of their income taxed at 14.3% gives you an effective rate of 5.2. And then you can see as you progress up the income level, what that turns out to be. Because we're always excluding that first 31,000, 32,000 essentially dollars of income, nobody ever pays the whole 14.3%, but you get closer and closer to that number the higher your income goes. And the very last column shows that for an income of $1 million, your effective healthcare personal income tax rate would be 13.8%. So it's a very progressive healthcare personal income tax, ranging from 0 to about 14% at the very highest income levels. And the median income in Oregon is around that $80,000 mark. So for most people in Oregon, their effective healthcare personal income tax rate would be somewhere between 8 and 9%. Again, this does not include the employer payroll tax credit. If my memory serves, when Charlie worked out the details, when you include the employer payroll tax credit, as a reminder, if folks work for a company that is also paying the employer payroll tax credit, the employee gets a credit equal to half of that amount. We decided on a 50% credit. And so, you know, if you're making $75,000 and your effective HCT is I'm going to use the 100 because it's better math. If your effective tax rate is 9.7%, then that means you would pay $9,700 in theory for your healthcare personal income tax. But if your employer is already paying say $20,000 on your behalf, then you could get up to a 10% credit. And so somebody making $100,000 would pay nothing for the universal health plan, because the combination of that effective tax rate and the credit they get from their employer would cancel out. And the huge proportion of people would end up in that category because they work for employers that would be paying the employer tax credit, and therefore they would end up paying nothing. So, and if they do pay something, so even if they're in that 100,000 income group and they're paying $9,700 in effective tax rate, so maybe they would get $8,000 back in terms of a credit, and they would only be owing 1,700. So that calculator that Morgan's developing is really crucial for people to actually plug in these numbers and find out what they would pay. I'll remind folks that adding something like an employer tax credit does complicate this plan and does make it hard to communicate. We don't have simple ways of communicating this, but it also makes it more fair, right? So we wanted the employer tax credit in there because it shifts the burden of who's paying for this plan a little bit more toward non-wage income and a little bit less toward wage income, right? And we thought that was a good balance. And then self-employed folks also would have a little bit less of a burden. So if you're self-employed and you're paying yourself, then you would have less of a burden for this universal health plan. So we added some things that complicated, some exclusion levels, the payroll tax credit, because we wanted it to be a little bit more balanced. So it's one of those trade-offs where we could make it simpler, but then it would be less progressive. Or we could make it a little bit more complicated and have it be a little bit more progressive. So this is just to give people a little clarity on what that 14.3% HCPIT means. Again, these are not the final rates people would pay, but it just is a little bit of a visual on what that would look like. Does that help? Yeah, go ahead, Bruce.
How many people will not get the tax credit?
I don't know that we know the answer to that.
I'm trying to remember from discussions at the finance committee, and what's popping in my head, I could be wrong, and maybe Charlie is laying winning things. I thought it was that 80% of people work for employers that
80%.
80, but I could be wrong. Does anybody, Richard, Charlie, does anyone remember that?
So we don't have a vetted number for this. I'm just getting back to Michelle's point about communication.
Yeah.
Yeah, we do have those numbers. We don't have them offhand right now because that was work that was done in the committee. So we can pull those up, and that will be part of our communication plan. And of course, built into the calculator, which will be one of our major communication tools. So we can include that. But basically, this is just to make the point of the progressive nature of that HCPIT. That's not a flat rate. Go ahead, Amy.
Yeah, just because the communication plan keeps being referenced, just a reminder, we ran through our very small budget for communication consulting. And my understanding from our last meeting when I asked about this is we don't have more budget for a year.
That's right. So go ahead, Amy, did you have more?
No, I mean, I just wanted to kind of state that because we have these numbers out there without any immediate communication plan other than whatever we ourselves can create.
Right, so the numbers in the plan that we're coming up with currently are not intended right now for the general public. The intention is to communicate to the legislature what this plan would look like and get their buy-in in terms of referring it to the voters. So our goal with these numbers is right now to present a plan to the legislature, hopefully get a piece of legislation that's referred to the voters for the 2028 ballot. And then, as we've discussed before, in the board's continuing work between September this year, 2026, and November of 2028, the work of the board is public engagement, right? It's getting the numbers and the plan in front of voters, in front of businesses, in front of healthcare, in front of anybody who could possibly be interested and affected, which is essentially everybody in this plan, and getting as much feedback and input as we can in order to revise those numbers. But our purpose right now is to put something in front of the legislature about what this would look like. That's what we've been asking.
Yeah, I understand that, yet every meeting we are in front of the public.
Of course.
And the people who are paying attention are the people who really, really want this or really, really don't. And many of the ones who really, really don't have access to communication money that we don't have. and they're gonna be putting stuff out there.
I'm not sure I have a solution to that, other than we're required to do our work transparently and in public, and our goal is to, stay on task and produce our deliverable, and then
I think I'm
our-
getting back to Michelle's point that anytime we have numbers, we, just having them up like this, we need more explanation, more, what the assumptions were, all of that on every single public facing slide.
Okay, I appreciate that feedback. Go ahead, John Wayne.
I'm kind of echoing Michelle and Amy's concern, which was also my concern. Is whatever we propose or recommend to the legislature, given those contexts and concern, I think it's extremely important to put at least two very important conditions or notes. One is whatever we recommend are still based on not very accurate, well, it's the best we have now, but subject to more revision, more accurate data. So
absolutely.
that's very important to put that as an important note. The second important note is whatever we propose in terms of revenue strategy, we don't have any public input yet. So it's a very important note to include it, that this was subject to further public input and will be changed. And that as a defense, because as Amy mentioned, all our information are public information. Those who want to want to attack the universal health plan, they will use any number. And in the previous meeting, I mentioned a flat rate can be easily defeated and slaughtered in a 30-second soundbite. And so we have to be very careful about packaging that, including those important two notes.
Absolutely. Okay, next slide.
Well, I'm sorry, Mary Lou.
Oh, sorry, Mary Lou.
And I got way late thinking what Jennifer was saying, and okay, I know what I was gonna say. I think one of the things that if we keep going back to the really ongoing public input of Lou Seneger about the unions. And I really don't know whether we have talked to the unions or not. And what they're saying because I've been asking Charlie before the meetings about the idea of not crediting the EPT. Because it makes a bigger difference when you do, I did the same kind of thing like this, Helen, and it looks much better.
Right.
For the personal income tax.
Right.
If all that EPT money stays
in the
for the
revenue.
plan versus giving it back.
That's right.
And Charlie and I have had philosophical arguments, disagreements on the economist view that that's part of your wages, and all of those philosophical things. But what it came down to is Charlie said, if those unions believe this is important enough, big enough that they want to support it, but if I'm really concerned about going forward with that 50% going back without hearing something specifically back from especially the big public.
Absolutely. That's a key group we need to.
And I don't know whether, when we brought it up before, it's like, well, we don't have, consultants or whatever, but.
Mary Lou, a reminder that, sorry, this is Amy, but a reminder that we did have unions at our focus group. And it's in the report from the focus groups. And there was definitely a mix of concerns and support. I mean, that's not all the work, obviously, that we need to do with unions, but we did talk to them.
But the way the report was put together, there wasn't a specific, the union group said this.
Right, and that was intentional.
I know that,
Yeah.
but as a result, it's hard to tell from reading that report exactly who said what about it. So that's my only concern, is that I just don't feel like I adequately have heard, what they're saying to us or not. And I don't know, maybe you've been having behind the scenes discussions. I'm wanting to ask.
I will just turn this over to our CECC chairs about the communications and how it has been planned out, how this will happen. And I would also just reiterate that as the plan continues to be developed. So for example, we can't have a calculator until there's a decision about what goes into it. So it is absolutely challenging to have all of this in public. And it doesn't always look pretty, but sometimes that's what has to happen. So, but in terms of speaking to specific groups, that is a different part of the communications and engagement plan. So I would, I'll just, if Michelle or Amy wants to lean into that, that would be great.
I don't have a lot to add to what Amy shared. Thank you, Mimi, and thanks, Mary Lee, for the question. It is an important one. I will say some of the groups that the legislature directed us to engage with are more difficult to make sure that we've reached kind of an adequate diversity of representatives. Labor unions, both public and private, because there is a finite number of them and they are easy to identify and get a hold of. I will say the outreach was very robust and comprehensive. And the invitation went to all of them that we were able to, I'm pretty confident that, you know, we reached out to all of the major private and public labor unions, and we had robust response. And there's not anything more that I can say because they did share their feedback on condition of anonymity. And that was a commitment that we made to them. So certainly in future phases of the work, more will need to be done. You are welcome, of course, to chat with anyone that you would like to, but I think officially as a board action, as part of our engagement work plan, I think it is accurate to say that we had multiple and robust conversations with union representatives, both public and private, and that is in the report. And I think that's what we had capacity to do in this phase of the work. And I appreciate you asking about it. And certainly the finance and revenue portion of the plan was something that they had a lot of things to say about. So.
Mike?
I was particularly in reflecting on our last meeting, I deeply appreciated Michelle's comments about how challenging all of this is. And I think we're all struggling about what's the wisest approach right now. And I only have the two minor comments. One is, you know, we've got to be very careful that we say clearly that this is just preliminary. For instance, some of you have met, but I haven't met with anybody or seen, you know, there should be some dialogue with us and the legislative office. And the fact that, so I'm assuming that somehow there's a magic process with them. But I'm very concerned if I get, you know, a conversation, I'll take an example of Jill Arena or what you all have seen with Bill Shao. If there really are much more substantial savings, and all we have is this stuff, I'm very concerned. And at the same time, I'm very hopeful that there are levers that we can be doing that could substantially make for our health plan to be an essential health plan, and that this stuff can work for Oregonians. So I'm just sharing with you. I'm, you know, I find the last 48 hours trying to observe this, I don't yet feel I have anything particularly wise to say it's exactly right. I hear people saying, "Oh, we got to go X," and I hear people saying no, etc. I would hope that maybe we could, you know, I'm inventing here, but maybe deeply appreciate this, have whatever conversation we have, but is there any possibility for us to meet in 2 weeks and decide this when it's a little bit more sober? And at the same time, I'm not trying to distract, but I'm sorry, Mary Lou, did you want to?
No, I'm
She was making a joke.
Well, I really appreciate the jokes. I'm just trying to figure out what is the right path.
Right.
Because my gut is exactly like Michelle's. This is, without, and Shunway said, without appropriately positioning this, anything more than preliminary, it may not be the wisest thing to do.
Yeah, I think that's a great point, and it kind of, let's just finish out these couple slides and then we can continue the discussion. So again, going back one slide, this is the revenue plan that we are talking about today. And with these elements and these ranges for what that would look like, in order to fill our revenue replacement target. So go ahead, 2 slides. So the pros of this current revenue plan is that these are very robust benefits, dental, vision, fertility, everything's still in there with very little, if any, cost sharing. There would be no more medical debt. These would be predictable costs that people can rely on, as opposed to sort of unknown increases every year, as is going on now in the commercial market. This is a very progressive tax structure. Again, no cost for anybody making 200% of FPL or lower. And then a varying rate between 0 and up to 14% personal income tax, depending on income. The medium household would pay 8 to 9% before any tax credit. The EPT credit shifts more burden to non-wage income. And then there are some built-in limits to rises in costs. We talked about the administrative structure. There's going to be some hard caps on our spending. And so this plan builds in a lot of cost containment strategies. And I think, this idea that it's a predictable cost for employers, and elimination of the human resources administrative costs is a real pro in terms of the businesses. Next slide. There are a lot of cons to this, and a lot of that is what we just talked about. This is a very difficult economic environment for any new taxes, business or personal or otherwise. There is a sticker shock and a communication issue around that 14.3% idea, though no one will pay that actually, and only millionaires will come close to that. There's a recent business advisory group to the governor's office who have recommended lowering business taxes. And so that's a bit of an uphill battle. We'd be going counter to that. And then these estimates are also based on a static environment. The Legislative Revenue Office made that point several times. If these kind of taxes were put in place, it's unclear how that would change people's decisions around their employment, around their employees, around their businesses. It's a very dynamic environment, and these estimates are based on a static estimate. And so that's something to consider. Next slide. But for purposes of today, we have 2 options. And again, reminder, this is our last opportunity so far without a special meeting to make a decision about our revenue plan so that we can start building that in. The option today that I would like the board to consider, the one that I would recommend, is that we submit this revenue strategy as it's outlined here today as our best preliminary guess of how we would fund the revenue replacement target. And then include with our report a very detailed narrative that captures what Mimi went over in terms of the opportunities we saw for possibly further savings, and really emphasize what Michelle has brought up a number of times and multiple board members have brought up, that this plan needs to be vetted by business community, by the healthcare community, by the general public, that we need input. We need to know which trade-offs would you prefer? Would you prefer we take this away and get this trade-off? Would you prefer, no employer tax credit or a lowered one in exchange for a lower HCPIT? That needs to happen. And we would include a pretty detailed narrative with this revenue strategy saying, this is our best guess based on what we know now. And there's a lot we don't know and a lot we haven't been able to explore with the limited resources of this board. So that's option 1. Submit it as is, detailed narrative about things that still need to be looked into. Option number 2 for this board is that we could discuss and decide that we don't like some element of this revenue strategy, that we feel really strongly that either one of the instruments needs to change or the proportions need to change. And that if that needs to happen, then what that would entail is a little bit of a discussion about that now, a special board meeting, which we're anticipating would be July 30th. But we would have to agree on what our goal is for what exactly about this revenue strategy we'd like to see changed. And then we'd have to have agreement on the levers that we'd be willing to use. Those are very detailed, big discussions. There's going to be a lot of different opinions about that. And then thinking about sort of our time, that's going to be a really big lift to do. If we decide to go with option 2, that we want something about this revenue strategy to change, then we would certainly have to have, like I said, that special board meeting in 2 weeks. And then we would have to have as a default that if we cannot come to agreement on the goal of that discussion or the lever of that discussion, that we need to default back to option 1 and just submit the revenue strategy as is with a detailed narrative about the work that remains to be done. Before we talk about option 1 and option 2, does anyone have questions about what I just proposed in terms of like where we are in this discussion? Okay. Any thoughts on whether we should go with option 1 or option 2? Go ahead, Judy.
Thank you, Chair. I would move to endorse option 1 to submit the revenue strategy as outlined here today, because it honors the due diligence of both the Revenue and Finance Committee and all of the work of this board, offering the legislature, sorry, I'm going into discussion. Offering the legislature the range of options and are thinking the pros and cons to put it into their court to engage with us and to modify as we've discussed.
I second the motion.
Okay, it's been moved and seconded to adopt option 1. Is there a discussion? Michelle, I see your hand.
Thank you, Chair, and thank you for the motion. I agree. I will be supporting this motion. I think with the limited time and capacity that the board has, our wisest course of action to, I think your question is a good one, Mike. What is the wisest course of action in the position that we are in? And that is to put all of our time and focus and energy not into trying to answer questions that I don't believe personally we have enough data to fine tune this much further. I think that we need to make sure that we're using what we have to frame this appropriately and thoughtfully in a comprehensive way and simplify it as much as possible. And that it, in my mind, that is our highest charge at this point. I think we've done what we can on the numbers, and that we need to go with option 1.
Bruce?
Yeah, thanks. I agree with Michelle that we don't have all the data and we don't have the time. But I guess I come to a different conclusion, which is I can't support option 1. I just have too many questions, and I think based on the discussion previously, once you put numbers out there, they get grasped onto. And I think this just needs a lot more work. And I mean, I would put 2 other options on the table, which are 1, to not have a section about revenue in the report, or 2, delay the report. Ask the legislature for a delay. I think we could get that, and be able to spend some time really filling in some of the holes, being able to communicate better, getting some of this vetted. I just think there's a lot of work to do, and I personally am not in a position to go with option 1. I've got a lot of questions about the complexity, about the progressive nature, about the need for 5 taxes in this environment. I just think there's a lot of questions, which I apologize. I haven't been a part of the discussion over the last 6 months. So I may be an outlier and a sole vote in terms of that, but that's just where I stand.
Conway?
I concur with Bruce's comments, and specifically, for option 1, if we are going to move for option 1, I would like to modify the language. Besides the 2 important conditions I mentioned, that has to be very visible, very explicit, not as a side note, that we are making those recommendations based on these 2 conditions. 1, we need further refinement of those estimates. 2, many of the important recommendation decisions, we don't have public input. And so these 2, they should be very visible. And then in addition, how we frame it. And I would recommend not to put the flat rate as the center. Rather, we emphasize this will be a progressive rate in this range. And the flat rate will be a signal based on that's a signal. Because if we put that as a forefront, it can be easily defeated. We don't have the weapon to fight the 30-second soundbite. So either, as Bruce mentions, not to include specific recommendation on revenue, or to modify our language in option 1.
Yeah, I would add to that, you know, there's wide agreement. I don't think there's anybody on this board that thinks that the work has been sufficient in terms of its detail or, you know, all of the avenues we need to explore and all the conditions we need to explore to submit this as any way near a final plan. And so what we have been developing, as Mimi mentioned at the start of our meeting, is a legislative concept for the continuation of this board. This board doesn't end its work in September. It doesn't sunset. We are only funded through June of 2027. And what we're asking from the legislature is continued funding, more robust funding, so that we can do the incredibly resource intensive work of getting input and buy-in from the business community, the healthcare community, the general public. None of us on this board is in a position to understand the implications of a plan like this. We need consultants and support and resources in order to get that information. We have spent our budget. We do not have budget anymore for the remainder of what we currently have been asked to do. We need to be allocated more money in order to get that information that we need to further refine this. And we've asked to do that work in the 2027-2029 biennium. With more robust funding. And so I wholeheartedly agree with what Chunwei just said, that all of this would be prefaced on, this is extremely preliminary. There are a lot of gaps and holes. There's a lot we don't know. This is our best guess that you've asked us to come up with. Delaying the report by 2 or 3 months won't be helpful because we still don't have the resources or the time or the money to get the answers that we need to do the further refinement. And it would eliminate the option to pursue some legislative concepts for the 2027 session. And I don't think that's in the interest of the board. We want to retain that. Basically, what we're hoping for with this report is to give enough of a sketch, enough of a skeleton outline of both what the plan would look like and what it would cost to do it, that we get enough interest from the legislature and then ultimately the population of Oregon, that we get the momentum to keep going and keep working on this. It's in no way final. It would just be a preliminary with a promise to dig deeper and do more work over the coming 2 years with a lot more resources, both in terms of staff and finances, in order to get better answers. So yeah, it would be with that framing, as you said. Go ahead, Mike.
Great comments, great discussion. I have a very basic question because I'm still torn here. I have had no conversation with the legislative office, but I mean, years ago is when I chaired the State Health Council. We did things like that, and now maybe because are we gonna ever meet with them, or?
Of course, that's already been in process. We've met multiple times with them.
Oh, okay, so
Yeah.
you and Mimi.
This
Okay.
Mimi and Lee and
Okay.
Judy and I.
I just have, you know, we just need to be so careful here about how, what we're trained, because I understand with the best of intentions, you know, there's something in my gut says we're shooting ourselves in the foot here, so. And yet incredible work's been done. We've done almost miraculous work with such, you know, limited funding. So I'm just sharing with you, I'm quite torn.
I think I agree with Bruce. I am not ready to vote today on option 1. I think that no matter what we say, etc., that 14% is just gonna be a killer. And I also believe that we need to find out about this possible removal of the EPT tax credit. Because if we could do that, I'd like to know the numbers on, you know, if we didn't do that, how much more does it give us and how much could we lower that personal income tax? And I just think, I hate to be the one that keeps dragging my feet and saying, stall the report. I heard clearly last time that was not what the majority of people wanted to do. But I still believe that a couple more months would help, Helen, so I will vote no.
Right, as a reminder to the board, we did take a vote at our last board meeting about whether we should have a discussion about whether or not to delay the report. That was brought up, and the board voted and decided not to pursue that path. And so that's not up for consideration today. We took a vote last time on that issue, but go ahead, Chenwei.
I just want to make a quick reference about why I'm a strong advocate for giving EPT credit to an employee. It's not just philosophical, it's a fact that since the beginning around World War II, the whole reason we accidentally got into employer-sponsored health insurance was because of World War II, because of the wage freeze, and that as a loophole to increase wage.
So it was, I understand.
So since then, the employer provided health insurance has been treated as employee income. So that's a fact. And so for this reason, it is important to honor that because there's a substantial federal subsidy. Because if you make income, say 20,000, if you say $100,000 income and you get a $20,000 benefit, that $20,000 should be your income. And if you are on a 10% tax bracket, then you have to pay $2,000 for your insurance premium as your income. And about 1.5 decades ago, economists did an estimation. That's called federal subsidy. That federal subsidy at that time amount to about 10% of our national health expenditure. And because of that, there's a two-figure, when I teach health finance, I always tell students, technically, US has been majority public finance. But if you look classification, most administration put US as predominantly private finance. This is ignoring that tax subsidy from the employer-sponsored health insurance. If you add that into our total expenditure and shift the payer, we have the slight majority, about 52 at that time, about 52% of our healthcare finance was public. And so this is for that reason. But the other reason is political feasibility, because there will be employee who did their own calculations, say at present, I pay nothing for my health insurance premium. But with universal health care, you're asking me to pay $5,000 or even higher. So for this two rationale, I advocate for giving credit. But last meeting I mentioned, this is not either or question. How much credit that can be subject to debate? And this is one of the key issues we need public input. We don't have that information.
Thank you.
Right, because part of the presumption would be that if healthcare is decoupled from employment, then what the employer is currently spending on healthcare for their employees should then, in theory, translate into higher wages. But we don't have any confidence or any assurances that that would happen. And one of the way to make sure that that money gets to the employees is to give the credit.
Yeah.
Is right? Okay.
I hear you. Thank you.
Okay, so there's been a motion to accept option one. It's been seconded. We're still in discussion. Is there any further discussion about the motion? Go ahead, Mike.
This is not making me any less torn. My gut is if at least someone could educate me in the next week or so about why we want to do this and that we've really thought this through, that's great. Otherwise, I'm asking for consideration of, can we have this vote in a special meeting in 2 weeks? I will be physically in Singapore, so this is not in my enlightened interest to be on a conference call with you all at 12 p.m. Singapore time, but my gut is I hope that that rather than calling for the question now, we have it in in 2 weeks. That's what my gut is saying.
Well, so the question is, are we ready to, go with option one now, or do we need further discussion? That's the question on the table. So the motion is to go with option one, to submit the revenue strategy as it is, with a lot of narrative and, consideration. Or if you're not in favor of that, the option you would be voting for is, we need further discussion. We need to have a special meeting in 2 weeks. We need to agree on a goal for what we want to change about the revenue strategy and the levers we'd be willing to use. And we have to also agree that if we can't come to agreement on those 3 things, that we still default to submitting the revenue strategy as is, because we've decided we're not delaying our report. We are submitting in September, so we need to do a final approval of the report in August. So if you're in favor of option one, it's going with it as is, and knowing that the work ahead is 2 years long. Or option two would be, let's give it a whirl. Let's try and come to agreement on a goal for our revenue strategy and the levers, and we commit to a special meeting in order to do that. Any further discussion about? Sorry, go ahead, Bruce.
Yeah, I just wanted to put option 3 back on the table, which is submit the report, because I understand the need to do that, but say we don't have a revenue plan, and give us some more time to work on the revenue plan. It's actually what the previous task force did. And my concern would be, I don't think we're gonna fix all this in 2 weeks anyway. So give ourselves some time. Let's submit the report, call it interim, be able to have time to work through many of the issues that came up today. I just think that's a viable option. I'll stop there. Thanks.
Okay, go ahead, Tim.
I just want to amend what Bruce just commented, kind of in the middle way, compromise. We can reframe that because of the 2 conditions I mentioned. We need more and better data, and we don't have public input. So we are not officially recommend any revenue strategy, but we give an example. That's why we have been working on, but this is not what we recommend. But we give something to the legislation. These are the examples we've been working on. But the reason we are not recommending this example is because those two conditions.
Okay, so there are 3 options on the table. Option 1 and 2 as outlined above. Option 3 would be to not include a recommended revenue strategy in our report because of the caveats that we've gone through, but to list some examples and some
What we have done today
frameworks
as
of what we've
example,
done
but
today,
not what we recommend
and
that.
why we don't feel like we can recommend them.
Michelle has her hand up.
Go ahead, Michelle.
I just want to reflect, listening to this conversation today and in many previous board discussions. I think many of us are saying that, from my perspective, saying the same thing. I think that it feels muddy to me because of the word recommendation. And my understanding and supporting option 1 is that we reframe the whole thing, like Dr. Chi and many others have said, to say this is our preliminary work. We're reporting on, this is our status update. And there's more work to be done. We're missing data, we're missing public input, and we need funding to continue this work. I don't see that as substantially different from what Dr. Goldberg is saying. I think that it's difficult because every time this has been brought to the board, the framing is this framing. This is our recommendation. This is our revenue strategy. That sounds, even to my ears, too formal. And I don't think something that we could defend or back up. And so I think that the concern is legitimate about, if we've been having this discussion, I think, for months. And if we haven't been able to reframe it in our own discussion, in our own slides, will we be able to reframe it for the report? I think that's a really valid concern. And I think it's really helpful to understand that the task force successfully said, here's a report on our work. We don't have a strategy to propose. We need more time. I think that's a nice way of meeting our obligation. I firmly believe we need to submit our report and tell the legislature what we have accomplished. And I am listening to this discussion. I think that the proposed option 3 is closer to what my goals were in supporting option 1. So I will be a no on option 1 at this point.
Right, so it's a really interesting point, Michelle, and in some ways, option 3 and option 1 could be melded, and to say that we would submit this revenue strategy as outlined here today as our best work to date with a lot of caveats and not as a recommendation. So option 1 and option 3 could be essentially identical if we don't frame the revenue strategy as our recommended strategy. If we just say, this is the work we've done to date, this is our best guess, we're not at all confident it's the right path, and we really need more time. So, yeah. Okay, Amy and then Judy.
Yeah, I agree with Michelle and what others have said. The option 3 on the table, I think makes the most sense. And yeah, and we would have to rewrite option 1 for me to be comfortable with it. So I'm leaning towards the option.
I'm gonna look at Isabel before Judy. Are we able to do a little bit of a live slashing so we can propose an option 3 and get it in writing so people know what they're voting on? And while we're in the, I'll let Judy go ahead and make her comment.
Yeah, thank you for the discussion. I would be willing, and I'm like thinking about Robert's rules, but I'd be willing to modify my motion to support option 1 with the combined features of the third option that was just discussed as a motion. I don't know if I can do that before we vote on the initial motion. That's a discussion point.
I think you vote on the amendment. And then go to the motion as I remember Robert's rules, but.
Vote on the motion first and then go to the amendment.
No, the verse the other way around.
Oh, go to vote.
You vote on the amendment.
Okay, so you can withdraw your motion and amend it. Okay. To be clear, the difference between hybrid option 1, option 3, and option 2 would be if this board in our current iteration, without any further input, wants to continue discussing the revenue strategy and modifying it in some way. That's the primary difference between this 1-3 hybrid and option 2, is if we want to have a special meeting to kind of come to agreement on sort of changing the levers in some way and getting new numbers. Just to put that out there. But Judy, do you want to withdraw your motion and amend it?
Yes. I'll withdraw my initial motion and amend it to include the features of option 3 as we've discussed. As well, you can help us with that.
Yeah, and we can work on a live, we can put it up on a slide so people know what they're voting on.
Question.
Go ahead, Cheryl.
So I think I could probably second that, but I feel uncomfortable with having nothing about a revenue plan. Like, to me, it's a draft. And so I have concerns about just skipping the revenue plan. I mean, if that's what I heard in option 3, so I don't know that I could go that far either. We spent 18 months on this in the Finance and Revenue Committee.
Right.
So I don't want to pretend like we didn't do any work on it, or that we haven't fleshed a plan out. Even if the board isn't comfortable with it, it's still a draft revenue plan. Could we characterize it as that at least? I couldn't vote on just setting it aside.
I wholeheartedly agree with that, and I don't think that was the intent. Folks can correct me if I'm wrong, but I think the intent is in the revenue strategy section of the report, we would detail the work of the committee. We would go through what we've come up with so far. We would list the elements of the revenue strategy and how we would come up with our estimated revenue replacement target. We would say this is roughly how it would work out in terms of an EPT and an ACPIT. However, the board has a lot of concerns about this. We don't feel like we can offer this as a recommendation because of all of the issues that have come up. We need more input, we need more buy-in, we need to dig into it more, we need to understand the impact on businesses. And so we would like to withhold our official recommendation and request that we spend the next 2 years continuing to work on this and refine it. But I don't think it would be
I'd
blanket.
be okay framing it.
Yeah.
Not the
That was
other.
my understanding as well.
That was yours.
All right, good.
Bruce says the same.
Okay, go ahead, Bruce.
No offense, guys, but I actually proposed option 3. And I actually was proposing to not say we don't have a recommendation on revenue. And I would not, personally, I would not, and Cheryl, I know there's been a ton of work done. I think we could say we've done a lot of work. But I think once you start putting out there all, here's where we landed, but we don't recommend it, I think people glom onto that. My option 3 would be submit the report as interim and have a brief page or two that says, we did a lot of work on revenue. We've looked at a lot of options. We've yet to be able to come to any sort of recommendation, and leave it there. I just think putting a lot of detail into that will be a problem.
Okay, so are we ready? Are you ready?
Which is option 3?
I'm gonna clarify on the slide right now, but if I'm getting, is that okay?
Would you like me to?
Yeah, so we wanna put a live slide up. Okay, so option 1 is submit the revenue strategy as outlined in the presentation today with heavy qualifications that it's not a recommended strategy, that we feel it needs more work and more vetting. Does that capture kind of go through what we've come up with to date? And then with a lot of qualifications and say, we're not confident about this yet, it needs more support. Option 2 would be, the board spends the next month doing its best to revise the revenue strategy to the best of its ability with different levers and trying to adjust the numbers somewhat before submitting it in our report. And then I put parentheses that would require the special meetings, so just put special meetings in parentheses after option 2.
So the meeting wouldn't be on July 30th, because that's more, so a month.
We're not gonna put a date, we're just gonna say we need a special meeting.
Okay, you said it.
Option 3, correct me if I'm wrong, Bruce, but do not include a revenue strategy in the report and just indicate that we've done work on it and it needs further work before we would put anything in a report. Is that accurate or?
Yeah, correct. And submit the report as an interim report.
Okay. Any feedback specifically on those 3 options as we've worded them? Go ahead, Chanwei.
I have a comment on both option 1 and 3. For option 1, again, we're kind of mixed between 1 and 3. For option 1, per my previous recommendation, for the revenue, what we have done so far for the revenue will be kind of appendix, because the main theme about our report on the revenue strategy is we elect this to 2 conditions. And therefore, at this point, we are still working on it. We will not be recommending it. But if you are interested in seeing what we have worked on, that's available as a kind of appendix. And that's similar with kind of my modification for option 3, that I kind of mix between 1 and 3.
I see that, yeah. Maybe in option 1, if you can edit that slightly to say that it is not a recommendation, instead of not recommended, just so not a formal recommendation. Yeah. Yeah, so it's like as we submit the revenue strategy as preliminary as preliminary, present the revenue strategy as preliminary structure as outlined in the presentation. That's right. Okay. Right, and then I put so Bruce, what do you think about adding to option 3 that you would include it as an appendix, or would you not even include it as an appendix?
apropos of Michelle's comments in the beginning, that you have to be careful about numbers being put out there. uh, I wouldn't be in favor of that. I'm not in favor of having a report that outlines that and in essence implies that I'm in favor of that.
Okay, so
So
then,
no.
okay, so then just for option one, Isabel, if we can add to option one at the end of it, you can say, consider including the numbers only as an appendix to meet Chunwei's consideration. Is that okay? And that would be how we would address that.
What consider?
Michelle first.
Go ahead, Michelle.
I have a clarifying question for Dr. Goldberg. On option 3, what would you envision that interim report containing? Because I'm thinking about the engagement that we did. The engagement that we did was asking people's feedback on the draft that we had as of February. And so would we include that? Yeah, I'm just curious what that report would look like in your mind.
Yeah, in my mind, it would be a page or two that said, we did a lot of work on revenue. We looked at the following, 5 or 6 different options, income tax, payroll tax, without putting numbers next to them. We got feedback. Here's what some of the feedback was. We've yet to come to a conclusion and a recommendation. I'd be happy to talk about, we looked at a personal income tax, we looked at a lodging tax, all these things we looked at. My concern is putting numbers and things to those, because we haven't come to that. We haven't even, we haven't agreed to do the 5 taxes. So I just think it's premature to get out there with that sort of detail. I think it's fine to say, we've considered a lot of options. Here's what they are. We got a lot of feedback. Here's what it was. And then more work to be done. And I would do that in 1 or 2 pages without a lot of detail, because I think we all still have a lot of questions about that detail. And I think, quite frankly, it behooves us to be able, I can anticipate a variety of questions we would get. And I think it behooves us to have answers to those questions if we're going to put a plan out there. And there's a lot of work to be done.
So Bruce, to be fair, the board did take a vote on multiple elements of the revenue strategy. The board has agreed on those elements that are currently there. We removed one group, which was the household rate readjustment. The board voted to remove that from our revenue strategy. We also used to have a Medicare Part B premium tax credit that we removed because we added in the Part B premiums to our expenditures. So the board has taken formal votes on every element that's listed there. And agreed that those are the elements we want in revenue strategy. We've had really robust discussions about those. And now we have agreement on those with those 2 changes that I mentioned about the household rate readjustment and the Medicare. And so what we're voting on today is really like sort of, now we're seeing the numbers from LRO about how those percentages actually work. And it's sort of just a final check on, now that we've agreed on these elements of the revenue strategy, this is how the actual tax numbers would look. Are we still okay with that? That's what we're voting on today.
Helen, that's great. I wasn't part of those discussions. I'm not prepared to vote for that. I would vote no against that. I don't agree with the plan as out there just yet. I still have a lot of questions. So if the board's voted on that, that's great. Then go forward.
Okay, it's just that you said that we haven't agreed on these elements, and we have. So that agreement has happened. Ellen, yes, go ahead.
I voted on those various things, sometimes with, conditions or whatever. But my understanding was those were still preliminary. I mean, I thought all of these things were kind of almost, straw proposals
That's
and
preliminary up there in option 1.
preliminary.
Yeah, but even in option 1, it says.
Okay, but I guess I just don't want to believe that my vote, because we had to vote that day on X. I believe that we still had the time where we were gonna see how these things fit together, et cetera. So that's why I'm still more with.
So
Bruce's
that's what we're
option
doing
three.
today, is seeing how they
Okay,
fit
that's why I'm
together.
on option 3.
Okay, Sean Wayne?
Yeah, I also try to wrestle between 1 and 3, how to come to an agreement. And first of all, despite we have a different opinion, I think we all share the same common goal. We want this universal health plan to work,
Yes.
and we don't want it to be defeated prematurely. And so part of the concern is that we don't want it to be defeated prematurely.
Mhm.
And therefore, one big concern, both mine and Bruce and others, is to put a figure there. So I wonder whether in both option 1 and 3, can we have, again, I'm thinking about the middle of the way, have a revenue strategy that only listed, these are the 2 we have considered without them. So we have considered those A, B, C, D, E, F taxes as possible. And we explain, because again, back to my first 2 conditions, because we lack more accurate data information, and because we lack public input, because given one of the ethical principles of this universal health plan is community ownership, the public should have a voice, and we still lack that.
Yeah.
And explain that why we don't put the detail.
Yeah, I think that is option 3. To say these are the things that we.
But
talked
we
about.
still listed.
Right.
All those options we have discussed and conditioned without giving the number, because
Right.
Bruce's concern is once number is out there, it can be a subject of criticism and attack.
Right, so correct me if I'm wrong, Bruce, but that, I think that is what option 3 is, that would, it would be a narrative about the discussions we've had with no numbers. Michelle?
I really felt strongly that it was important to agree with the point that Mary Lou made. I was also part of all of those votes, and I would not say that we have agreed on this revenue plan. At every point, the pressure was, we can't get to the next step until we have some preliminary decisions. This is just preliminary. This is just draft. And then today, just now, at least what I heard, how I interpreted it was, the board has agreed. That is exactly the concern about the pressure today to sign off on this revenue plan. Because even if we have a discussion where we contextualize our votes, the next time it's presented as a recommendation, a decision. That comment right there increased my level of concern. That is not that does not reflect the way that I have voted in previous steps. And I would not say that this is a revenue strategy that I feel confidently is a recommendation of the board. I feel that we have made very preliminary votes in order to move to next steps, to get more data, to do more number crunching, to get it to LFO, but not to agree that this is our proposal. And I want to say that for the record.
Right, and yeah, I think that's understood, that this is, like, again, this is a preliminary, represents the work we've done, this is our best guess to date, but it's not a formal recommendation, it just kind of lays out, here's what we think the expenditures are gonna be, and in order to get to that revenue replacement target, here are the elements that we've considered in terms of how you could get there, and here's how it would work out in terms of the numbers, but we're not saying that that's something we'd recommend because we think it needs to be vetted more with the public, with businesses, with healthcare. But it would just, option 1 would just lay out in detail kind of what we've gone through, and that the board has agreed on these kinds of elements, that they are good ideas in there, but it's not the final plan because we need 2 years more of work, more consultation, more input from more interested parties. So it would just go through it and explain that that's where we landed so far. But would say that we wouldn't be able to go forward with a recommendation about a revenue strategy, the official revenue strategy, until we had 2 more years of work and more funding in order to vet it better. I'm not sure who is next, I'm sorry. Is it Mary Lou?
I guess just one thing that I would say, no matter what we do, and if we have a revenue part in the report, the other thing that I think needs to be stressed is kind of those principles that we worked on, the the things about the equity and the progressiveness, and I just didn't hear that said before, but I'm still with option 3.
Go ahead, Mike.
great comments. I mean, I appreciate the tensions. I'm wondering if the wisest thing to do right now is to acknowledge that there are tools and there are levers that we're going through an iterative process. We're gonna submit a report that Lee and Mimi has been working on, and that I wouldn't characterize this as, now, we're not delaying it for two years, but it may well be that as we do some additional work, we'll get to a point where we will be quite comfortable doing that. That might be 3 months from now, that might be in dialogue in the spring. So I just want to be careful that we're not kicking the can down the road from my perspective, but given that, I'd be interested in Bruce's final words.
Go ahead, Bruce.
I don't know if these are my final words. Sounds like I'm dying, Mike. You last said, no, I want to tag on to what Michelle said. I think words are really important, and how we characterize this is really important. And I think there's a big difference between, Helen, you said in response, and I quoted it, this is the best guess to date. The best guess to date to me means that's a plan that people have agreed to. I think we have to be really careful. I'm hearing that people didn't agree to a plan. They agreed to discuss something. And I would just, again, I think we could wordsmith all day. The less we say, the better. And to just say, we discussed a lot of options. Here's where things that were discussed, and there's a lot more work to do. I just think that's the better part of valor, because I would hate for any of us to be pushed into thinking that, some sort of discussion was actually a vote of approval. And I'm hearing some of that.
So I believe there's still a motion on the table for option one, to submit the revenue strategy as a preliminary structure, with the heavy qualifications, consider including the numbers only as an appendix. But you amended the motion, for that, and I don't believe it's been seconded. Would anybody like to second that motion?
I second it.
Okay, then I see Chun Wei's hand up. Is there further discussion about the?
Yes. One important rationale, if we decided not to put a number, but just put a strategy in our report, whichever options. We can include in the language in our report. Something I mentioned last time in our emergency meeting. Oregon was the world's first pioneer to go to the public. Spent 2 years to update, to revise initially already developed the OHP prioritized list. After years of work, it's already developed, but then because of the public objections, we took 2 more years to refine it. And this is a step we haven't done. That in order for this universal health plan to get public buy-in, this is the big chunk of work we haven't done. Oregon being the world's pioneer, we need to remind our legislation about this, what we have done in the 1988 to 1990s.
None of them were there, yeah.
Yeah. Okay, so there's been a
Amy's
motion.
got her hand up.
Oh, go ahead, Amy.
Yeah, I'm just wondering in option one, the word consider,
Yeah.
when does that consideration happen? Like, again, it feels like we're voting on something. It might not have all the same agreement, and then like who's making that decision?
Yeah, so if the board votes for option one, if the majority votes for option one, then we would have to have a follow-up discussion about, do we put the numbers in a revenue section of the report, or is it just as appendix? But the point is that the numbers are in the report in one place or another, and we would have to decide that at a later date if the board opts to go with option one. I think that's worth further discussion, but basically option one means the numbers are included with our discussion. It's just a placeholder for now, and then we'd have to decide that subsequent. It just depends on how, if the majority votes for option 2 or 3, then it's irrelevant, but we don't have to get into that discussion right now. Anything else about the motion on the table? Okay, so we're gonna do a roll call vote, and if you want option 1, if you prefer option 2 or 3, you would vote no on this motion, and then we'll have subsequent votes. So in favor of option 1, and then we can entertain motions for either option 2 or option 3 or both, if this motion fails. So the motion is to approve option 1, to submit it with strategy with numbers, either as part of the body of the report or as an appendix. Let's do a roll call vote.
Helen Belanca,
Yes.
Chun-Wei Chi,
No,
Amy Fellows,
No.
Michelle Glass,
No.
Bruce Goldberg,
No,
Judy Richardson,
Yes.
Cheryl Ramirez,
Yes.
Mary Lou Henrich,
No.
Mike Leahy.
No,
Thank you, everyone. That's 6 no's and 3 yeses.
Okay, so that motion fails. Would anyone like to propose a different motion?
I move to consider option 3.
I second.
Okay, option 3 has been proposed. Is there any discussion on option 3?
Um,
Go ahead.
Actually, I'd like to propose modify the language a little bit. As I earlier mentioned, we can include the language of what are the options we have considered without the number. So because the current language said, do not include strategy, because the word strategy, the content can be very broad.
Mhm.
And I don't know whether Bruce agree with that. I think your earlier comment you mentioned about we can list it. These are some of the strategy we have considered, like tax options, without giving any number. Is that correct, Bruce?
yes, but I'll be just a little clearer about that. I mean, I wouldn't want that to be taken as an assumption that everybody on the board agrees with those five options. I personally think it's too complex and too many. And we should give some consideration to simplifying the revenue plan. So as long as we did that, I'd be very happy with that.
So when it says do not include a revenue strategy, it would mean basically like sort of the framework of these revenue instruments and the proportionate makeup of the revenue replacement target. So if we modified option 3 to say do not include the revenue strategy, comma, but solely include a narrative about the various revenue instruments discussed and indicate it needs further work. If we worded it like that, does that capture, Bruce and Chun-Wei, what we think should be like? So we could just have a narrative say, we talked about this, we talked about this, we talked about this. And it will include everything, not just the 5. It'll include that we did talk about a sales tax and we did talk about a Medicare premium credit if the Medicare premiums were going to continue to be paid. It'll include everything that we talked about and not land on those 5.
That works for me.
It's also open to the public input. Not an exclusive list.
Oh, yeah, and acknowledges that it's not an exclusive list. Revenue instruments discuss, and also acknowledges that it's not a exhaustive list, I would say. Okay, so Chun-Wei, you proposed option 3 as a motion and it was seconded. So are you proposing option 3 as it's written currently on the board as an amended
Yes.
motion? Okay, and then it was seconded, I believe. Is it still seconded?
Second,
Okay, okay. All right, any further discussion about it?
I just have a question.
Go ahead, Cheryl.
What does that look like when we're putting this in front of legislators and we don't have any sort of a draft revenue plan? I just wonder if I were a legislator and I didn't see any numbers, nothing, and we've been working on this for 2 years, I would be skeptical. And so what are we asking them? we didn't complete our assignment. And can we have 2 more years of funding for this board? I kind of worry about what that response will be. And given the budget situation that we have, which, Bruce talked about earlier, it's like, well, of all the things that they could put funding into, are they going to choose this? I don't know. I worry about that.
Yeah,
So I'm just putting that out there.
I think it's a really good point. I think, it could be considered our first and foremost task as a board is to come up with a revenue strategy, partly because the task force did such great work to lay out a framework of how the plan would work. And the one thing that was missing from that task force, an obvious missing piece was a revenue strategy. And we have dedicated an enormous amount of resources, Milliman and Echo Northwest and the Finance and Revenue Committee, and the time and effort of this board and multiple consultants to coming up with our understanding of what a revenue strategy would look like. I think that is the main thing they're gonna be looking for from us, even if it is preliminary, even if it is couched in this idea that, it's not done yet, it needs a lot more vetting. I think that's what's gonna be looked at, and I wholeheartedly agree with Cheryl. I think the chance of getting further funding for this work, if we submit a report without a revenue strategy, is pretty limited. I think they would see this as not a board that can deliver on what it's been asked to deliver. And that our consideration for further funding, might be at risk for that. I think that's a very real risk.
If I could just have a point of clarification for the appendices or the appendix and what would be included. Would the memos and reports that have been created to date be included in the appendix? Because those will have numbers in them. So there's.
Yeah,
It didn't, so I'll just leave it at that. I just need clarity on that.
right. We
Thank
have
you.
reports from Milliman and from Echo Northwest, which include all of these numbers, and those,
And they're already posted.
they're already posted. Those numbers
They're
would
out
be
there.
included as part of our report because those are consultants we paid for
Yeah.
to advise the board. So the numbers are gonna be there in those reports, one way or the other. Michelle?
I want to appreciate the question. I think it's a good question for us to consider. I would just offer 2 things, 2 thoughts. One, I'm not sure bringing forward numbers that we can't fully defend or back up helps make the case that the legislature should continue to invest in us any more than being really honest and saying we used all the resources and time that we had and did really good work. And rather than bring you something that is easily misconstrued, misinterpreted, and could create confusion and potentially alarm, we are instead saying we need to continue this work so that when we bring you something, it's something that you can bring to your constituents and defend as well. I don't see that as being any more inherently risky. I think that the chances of us not being a priority of the legislature and the budget at this time is the case regardless. I think that's just a reality that we all acknowledge. Secondly, I would say when we presented our interim report, we dropped the ball. And I'll say that for myself specifically. I think that we have an opportunity and there may be additional steps we need to consider and go through, such as going through DCBS's communications department, but we could potentially write our own press release to be really clear about why we're bringing the report in the format that we are. We can, I've heard the chair say multiple times, that you are meeting with legislators. That's great. You have an opportunity representing this board, if we make this decision, to message to legislators ahead of the report landing why we made this decision and what it means. Like, I don't think we drop a report with no context. I think we have an obligation to frame this ourselves, to message this ourselves to key legislators, to key partners, and to send out a press release and not leave it to others to make of it whatever they will. I think that that's something we could improve from last time.
Thanks, Michelle. Go ahead, Jonathan.
And also, I concur with Michelle, and also to try to address your concern about with our number, I suggest in our report, we can write the board, particularly the finance committee, has worked extensively and come up with very detailed calculations. However, the board are not in consensus and are not comfortable in publicize those numbers. And that's why we don't present our report, those numbers. As a rationale to explain, we did a lot of work, we have numbers, but the board doesn't have consensus or not comfortable of using that number. That's why we don't present the number in our report. And also emphasizing Oregon's pioneer work that OHP took 2 years of public input. We don't have that yet. And that's a very important rationale for the legislature to fund our further work, particularly public engagement.
Okay, so there's a motion on the table to improve option 3 as it's written on the board. It's been seconded. Is there any further discussion?
Call the question.
Okay, let's do a roll call vote.
Helen Belanca,
No?
Chenwei Chi.
Yes.
Amy Fellows,
Yes.
Joe Glass,
Yes.
Goldberg,
Yes.
Steve Richardson,
No.
Cheryl Ramirez,
No.
Mary Lou Henrich,
Yes.
Mike Leahy.
Yes.
Thank you. That's 6 yes and 3 no.
Okay, and then just to be clear, option 3 would mean that there's not a special meeting because the special meeting would only occur for option 2 if we were gonna continue that. So just as a clarification for that, but yeah, Lee, you have a question.
Yes, so given this contingency, I would like to remind board members, there's a draft of the report out. And it does include a financing section on which I've received very few comments. It would be particularly helpful at this point in time for people to make sure they review that and let me know what they are comfortable with and what they are not.
Thanks for that reminder, Lee. Yeah. Please look at the report, everyone.
I commit to do that, Lee, because I
Thank you.
only gave you 33 comments.
My kids have passed because I got a lot of comments.
Go ahead.
And if you wouldn't mind clarifying, what will be included in the appendices? If that includes everything, all of the white papers, and all of the work that has been provided by our consultant groups. I just want to make sure that everyone is.
I mean, it's my opinion that if we paid for using public money, work and information and advice from consultants, that we are obligated to publish their report as part of our final report. I think that's a sort of a process question that we need to think about a little bit more, but it's my understanding that any reports that we get from consultants, moving, you know, the previous reports from Healthcare Associates and all the other ones, that those all are part of our work that we use public dollars for and they have to be included. But does anyone have a different thought on that?
I agree with you.
Amy?
My thought wasn't specifically on that, but a reminder that every single time numbers were presented to us from the consultants, many of us had concerns, for the last 6 months. So
Right.
just kind of verifying again, we have never had consensus on the numbers.
And we would have to explain that and go into detail about that in the report. Again, as Lee said, please look at what the report says in that regard and make sure that your voice is represented in that narrative in the report. Michelle?
Thank you, Chair. I want to say 2 things. One, this vote today is about our obligation as board members in my mind, and not a reflection on the excellent work that Lee has done. So Lee, my apologies. I understand how this impacts the body of work you've been putting so much time and effort into that I really appreciate. And so I just wanted to say that. And then the second thing was, I do not feel that it is our responsibility to attach all of the documents that our consultants have brought to the board, to our final report, to our next report to the legislature. I think we do have a duty to publish them, and we have. They are all on our website. They are all in our meeting materials. And there are many. There's slides, there's documents, there's memos, there's updated memos. And so I think it would be, in my mind, it does not seem necessary to decide which of all of those voluminous packets we attach to our final report. And if then we have to explain in our final report, contextualize those numbers, then I think that defeats the vote that the board just made. So I would encourage the board to ensure when we're reading the draft report from Lee that we are aligning with option 3 that the board just voted on. And I will also commit to reading it.
I agree with Michelle on that, that they are all public documents already. And that I don't think we have to, I mean, how heavy is this report going to be? Everything, so I agree with Michelle.
Can we look into that and get some advice from our agency?
Yeah, just, the question also comes up, sometimes the consultant reports are referenced in the work that we've been doing, so that would, which would be just sort of as a courtesy to readers to include it in an appendix, but we will get some information. Okay.
Could just give a link to them on the website.
Yeah, we have a couple more agenda items, so I'm gonna ask. Is there comments that need to be considered before we move on, or it's 12:05, so we've got.
Very clearly, Mimi shared this Washington report. There's no, an alternative to having a voluminous 300 pages, killing another tree thing, is just to have have links as an appendix and not put yourself through all of that work.
Thanks, and John.
Just related to the options you just voted, when we write that report, I think it's vital to remind legislation and for us as well, that one of the proposal we for the legislation is to put a ballot measure in 2028.
Right.
And given that, it's even more critical to engage in the public. Because before we want the public to vote, we need to engage public.
Yes.
Otherwise, this will be easily defeated.
Absolutely. Yeah. Okay. Let's move on. You can skip this slide. I want to have Lee spend like 5 minutes on a little update on Medicaid. Well, let's see, we've got total 5, so we've got.
This can probably be skipped because there's like no vote or doesn't change.
There's no vote, but it does answer a question that was raised last board meeting, so I do like at least getting to your bottom line. I'd spend like 5 minutes, kind of what you learned. Well, what do you think? 5 to 10 minutes, and then 5 minutes on information technology.
Yeah. Okay. Yeah.
Okay, and then I want to save time for public comment. But yeah, we let's go through this because this came up as a question last time, and we want to make sure that we understand where we are with Medicaid.
Okay. Yeah, so first slide, the question was raised, this is just directly in response to the last board meeting, where someone asked, what can Oregon do to integrate Medicaid into a universal health plan without any new federal approvals? Next slide. And we'll spend most of our time here and then probably jump to like the bottom one slide. So this is just a broad structure of Medicaid authorities, kind of starting from the inside and then imagining you're adding layers. So we start with our Medicaid state plan, which is really the baseline. This establishes your very basic required populations and required services. This is subsequently wrapped by what are called state plan amendments or SPAs. These modify the basic plan, so they can modify them in the ways that you see listed there: eligibility, benefits, payment. Interestingly, the 1915 K or K plan is actually also in the state plan amendment category. Now, what's interesting about state plan amendments is that they are they don't expire essentially. So once you have a state plan amendment in place, it remains in place kind of for the duration. So when we're thinking about things that don't need new federal approval, it would be these state plan amendments. They're going to stay regardless. Now, on the outside, we have waivers, and this
Can I interrupt you really quick?
Absolutely.
And everyone else chime in too, especially Bruce, but my understanding in terms of Oregon state plan amendments, we have expanded eligibility in ways other states haven't. Expanding up in terms of income level eligibility up to 200%. We've expanded to undocumented folks that they are also eligible. We've expanded benefits. We pay for benefits like gender affirming care that other states don't pay for. Those are the kinds of things that we're talking about that are in our state plan amendments. Is that right?
Yes, that's correct. We have the ACA Medicaid expansion is in there, certain adult folks. There's 12-month postpartum continuous eligibility. There's some different things on pharmacy. State plan amendments also, they're very operational. There's a number of these every year. So this is a really kind of ongoing sort of thing. There's maybe around a dozen a year.
Yeah.
Yeah.
I'd just like to clarify that undocumented are not on Medicaid. We have our Oregon Healthy Option or Healthy HOP
That's
plan.
correct.
Oh, yeah.
It's all state money. I just
Oh, it's
want
all
to
state money.
clarify
Right,
for,
right.
for
Okay,
anyone
right.
listening. that
Right.
We are not using federal money.
It's all state money, yeah.
Thank you.
So, but the state plan amendments, as you said, those are things that we wouldn't need waivers to continue, like that would continue regardless of if we ever got federal waivers.
Yeah, they wrap around the very basic plan, and they do not expire, as I mentioned. Amy? Was that your hand?
Yeah, just a reminder, the K plan is focused on home and community supports for disabled people using Medicaid funding, but since this board has never really had deep conversation on long-term care, including home and community supports for disabled people, I just wanted to state that.
Yep. Thank you. Yes, it's a very important one, and it does fit within the state plan amendment thing. So then on the broadest level, we have waivers, and this is what really kind of defines Oregon Medicaid as the sort of innovative, value forward kind of entity that we think of it as. The big one is, of course, the 1115 demonstration waiver. This is the one that allows a lot of, what we consider to be Oregon Medicaid to be in place. So this established the Oregon Health Plan back in 1994, and it established the CCO model back in 2012. Subsequent renewals have expanded integration of physical and behavioral health, oral health, social determinants, quality, doing things like the sustainable growth rate. Now, importantly, and then there's also 1115 substance use disorder, as well as waivers related to home and community-based services. The 1115 is kind of the big one that we tend to think about, though. Now, waivers are not like forever. Waivers are for 5-year terms, and our current one is set to expire on September 30th, 2027. With that, I think we can jump ahead to 27. So Oregon Medicaid without waivers, you can get a quick look here of what remains, assuming that you're not modifying, the state plan or state plan amendments, and what goes away. All that stuff with CCOs, global budgeting, quality-based payment, health-related social needs infrastructure. A lot of that continuous eligibility stuff is also embedded in our demonstration waiver, so that would go away. And substance use disorder, residential treatment, a lot of community integration services would also disappear. On the next slide. So really, if you're talking about not getting any changes to the federal government, what you're talking about here is administrative alignment. That's your non-federal option. And this does not fundamentally change Medicaid. Like at its core, you're not changing it. It's going to be legally distinct. It's going to have its own money flow, its own rules, its own coordination with the federal government. What you can do is kind of, as I like to think, paste a facade in front of it so that at least from a provider or a consumer perspective, it feels like it's aligned. And so where legally permissible, you can try to have single, points of entry for eligibility, member communications that look similar, provider directories, quality metrics. Again, this is all going to be subject still to federal regulations, but you can kind of put that facade in front of it that makes it feel more integrated, although in the back room, you're still shuffling between offices. Next slide. So the bottom line, with no change to existing federal approvals, as I mentioned, administrative alignment is really going to be your focus, trying to make it feel to those outside the system like it is part of the system, but it would remain distinct. Also just noting the importance of getting that waiver renewal in process. Without our 1115 demonstration waiver, we'd be looking at a Medicaid program that looks, the way Medicaid looked in the 1990s, which is to say something that's very medicalized, something that prioritizes institutions a lot more than our current system. And then also mentioned a lot of ideas around CCOs. There are state plan amendments related to having sort of centralized managed care. Because Oregon has leaned really heavily into the CCOs, we don't have those activated. So that's a possibility that could be explored. But again, that does require then getting that SPA, so there is a federal approval element in there, but that's sort of one, maybe half step as opposed to having to take some bigger steps. Bruce, I'm sure you have comments, so I will probably defer all questions to Bruce, but there you go.
I think, given the time, probably another day.
Yeah, so, but the question was, if we don't get a federal waiver for Medicaid, do we need a federal waiver for Medicaid in order to incorporate it into the universal health plan? And like, the answer is technically no. But it's still, it would be ideal to have that waiver so that we could incorporate it more fully and have it be a more uniform plan. Okay,
Oh,
Go
can I
ahead,
just
Jo.
say, this is just a comment, you decimate the SUD residential system if we didn't have a waiver for that.
Can you say that again?
We would decimate the SUD residential system if we don't have a waiver for that, because it doesn't, the waiver allows the business model that they need to be in business and to serve a lot of clients, because otherwise they'd have to observe the no more than 16 bed rule. So, in order to get Medicaid funding. So now they can have larger residential treatment facilities and still get Medicaid. That's really important. So that's one that I would advocate strongly
wrinkle,
for.
yeah.
Yeah.
Okay, thank you, Eve, for that follow-up. Appreciate it. And then Mimi, you want to talk about IT?
Sure. Keeping the theme of making things brief. All right. So for today, I thought what I would like to do is just include some elements that would be in the 2026 report. Talk about what should happen in 2027 and 2029, the work that needs to be done. And then I don't know that we'll get to discussing guiding principles in a desired future state. That's a discussion that actually was held at the transition committee. And so I think we will have the opportunity to do this at a later date. So we'll go on to the next slide. Oops. Okay, hold on. I'm like, not that again.
This is Groundhog Day.
Okay, thank you. All right, so the report content, again, this will be a very sort of what will go into the report that goes in front of the legislature will be very general. It has to do with things that we have discussed, but things that need to be in a universal health plan information technology strategy. So there will not be specifics, but it will be very much a just kind of a general guideline of things that should be included. The things that I would like to get feedback from the board, though, are sort of the guiding principles, and I'll present a little bit of that, and then just our future state. Again, we can have this conversation a little bit later. Other things like the partners and ecosystem compliance and risk framework. A lot of these things are very detailed and complex and are going to be taken on other than just stating that this needs to be in an IT strategy. That's kind of the level that it's going to be at. It's going to be very basic because obviously this is not something we've spent any significant amount of time on. Next slide.
Can I have a quick comment?
Yeah, please.
Not about your presentation. Isabel, could you please remove the comment so we can see the screen bigger?
Sure.
Yes, thank you.
Yes. And also, as I mentioned to our transition committee people, and I got a volunteer, anyone who's really, let me know what you like in what you know about IT, always happy. However, what does need to happen, and this is a big portion of the asset we're going to put before the legislature and our legislative concept for our phase 2 is you clearly need an evaluation of what should be done. So a detailed financial analysis, and then really to create that enterprise architecture. So to look into that, look into financing and authority decisions. What type of team are you looking at? And then a roadmap for development and rollout. So like really the nuts and bolts of what it should be, which of course would be discussed with the board, and then how it could be. Next slide. So these are guiding principles that we discussed with in front of the transition committee. And I also like to point out, we have our local expert, Amy Fellows, who has done a significant amount of work on the High Talk Committee in Oregon for Health Information Technology. And Oregon does have a strategic plan for health information technology via the OHA, and there's a lot of work that happens there too. But these were some of the guiding principles that we talked about at the transition committee and that they presented. So we'll just go on to the next slide. And then I think this is something that is important to think about when we talk about a desired future state. There's sort of the desired future state of health information technology in Oregon writ large, and then there's a desired future state of what should an IT system that delivers a health plan to everyone in Oregon look like. And those are not synonymous, but of course they're integrated. So as I said, those are some of the elements of the future state. And I think with the especially with a nod to the Oregon Health Information Technology, really that accessible, simple, engaging, and reliable interface for everyone who's an Oregon Universal Health Plan participant, includes providers, and of course, the crucial aspect of data protections, trust, patient consent, et cetera, and minimizing administrative burden. So there are other things that would go into that. But again, this will be perhaps at a later board meeting, we'll be able to have a further discussion. Mike?
Oh, just quickly, I'm grateful that I didn't have to do with you all at midnight in Singapore, but I do want to share. I'm meeting both with some people in the IT area from the Ministry of Health in Singapore, as well as the EPIC program team, that they're basically doing a countrywide system very similar to some of the stuff we've been looking back. If there may be some things I'll be able to report next time, we'll see.
Super. My other thing is that you did before give us a little bit of information, and when we talk more about kind of, I have this vague thing about Washington State and what they're trying to do and what they've done and how they did it, and
Yes.
and so what we can learn from them.
Yes, that was a presentation.
Piggyback on those, so that just kind of popped into
Mhm,
my head that you've done that before. Maybe an enlightenment when we go back to this topic again.
Okay. Yes, Tony.
Just a suggestion that British Columbia is one of the world leader and pioneer in integrated IT system.
I'm sorry, could you say, I just.
British Columbia,
British Columbia, yes,
Okay.
yes, and
one of the world pioneer in integrated IT system for universal healthcare.
yes.
And then Taiwan learned from them and fully developed, become one of the world leader in an integrated IT system for universal healthcare. So the two countries, BC and Taiwan, can be a good learning model.
Yes, and I did reach out to our, the person who had spoke in front, I can't remember which committee before, but from British Columbia.
Finance and revenue.
But did not necessarily, or didn't hear back from them, but yes, the British Columbia system is very interesting and has a lot of different types of complexity. We just don't have time to go into it today, but yes, and Taiwan, of course. All right, I think that is probably. So quickly, what's next? Well, no virtual only meeting for you all. So on August 20th will be our next meeting. Echo Northwest has created a memo which on economic impacts. It is a memo that sort of talks about what economic impacts one should look at. I look at it as very descriptive, a way to outline, these are the questions that need to be asked, and this is how you might go about asking them. So I think it's really beneficial. Obviously, it doesn't answer the question because we don't have a complete decision about what the revenue plan would look like, but I think it's very, very useful. We're going to talk about our phase 2 legislative concept. I'm just gonna stop calling it a final report. I'm gonna say the September 15 report review and approval, and then prioritizing topics for September in 2026 and June of 2027 is what's coming along.
I will add to that I anticipate at our August meeting, again, assuming that everyone's gonna provide written comments directly to Lee, But then we're gonna reserve some time on our August 20th meeting to look at how the revenue section has been organized and worded and make sure it reflects our priorities. So we'll hold some time to make sure we do that. And then I want to have some discussions with Mimi and the staff about the appendix question. I just feel like we need to do a little bit of background on that, and then that will also be an issue for discussion and decision at the August meeting. But basically, the paper should be, the interim report, the September report should be very, very close to final. And again, that August 10th is the last day to submit comments to leave written if we need to sort of resolve any issues, but they should be relatively minor at that August 20th meeting so that we can submit it on time. And then Judy has offered to draft a letter to the governor's office regarding the Medicaid advisory group and their report and how it aligns with our work. I assume we will have that on our agenda too, to take a look at that. And then anything else? Do we need to, again, as Mimi said on here, part of our agenda on the 20th, we'll be thinking about what our work is ahead, what our topics should be and how we should proceed between September and June. In our remaining time together of what that work looks like and what the board wants to do with that time. So we'll have some time to discuss that, but anything today that we should keep on our list of future topics? Go ahead, Jenny.
The two issues I brought up in our earlier discussions for the future next after the post-September topic. One is, again, this is a long road to get more data to refine our finance. And two is public engagement.
Okay. Okay. Cool. Anything else? Excellent. Okay, we have a few minutes for public comment. We have two people signed up for oral comment. We can hear from them.
I think we
First,
have more than that.
for oral.
Yeah, I think there's 5 on that list.
Oh, so all these are oral. Sorry, I misread that. I misread what you have here. So 1, 2, 3, 4, 5. Yes. So 5 people signed up for oral comment. The order will be Joanne Holland, then Colin Stackhouse, then Mike Huntington, then Lou Sinninger, then Todd Ferris. So Joanne's here.
Oh, Richard,
Oh, yeah. Yeah.
sorry, and also Richard Gibson, apologies, that got missed.
Okay, my 6. Okay, so I'll put Richard on at the end there. Okay.
Yeah, sure.
A little sore.
So yes, a reminder for all our public comment, there's a 2-minute time clock on the screen. We ask you to contain your comments to 2 minutes, please.
I'm Dr. Joanne Holland, Doctor of Veterinary Medicine and physician. I've been running an independent medical practice in Drain for 21 years, living in that community. And I wanted to urge this board to consider incorporating a direct primary care public tier into rural practices, for rural practices specifically. It's sort of similar to what they do in England. I'm asking you to review my written suggestions. I believe that your rigid fee for service with an exclusivity model will drive clinics increasingly into an assembly line and high volume model of practice, which would end up being primarily in the higher population areas, and that rural patients would have more difficult access. I think it would be a stretch to expect Oregonians to vote for increasing taxes if they don't see an increased hope for better management and more access to doctors. In the second tier option, I believe that small communities would be able to project a stable income for a local physician, offer them to offer incentives to start small businesses in these small communities, such as offering these some of these empty buildings or increased startup cost coverage by locals. And that that there may be physicians who are tired of a medical hamster wheel who'd be willing to trade to get a more engaging and have fewer patients and more time with their patients in exchange for lower but acceptable pay that they could project how much that would be. I want you to think about that and consider it in your many months coming discussions. Thank you.
Okay, thank you. Thank you. Okay, Colin?
Hello.
Hi, I'm Colin Stackhouse. I work with Healthcare for All Oregon, mostly on our social media and other kinds of communications. And I wanted to sort of echo something that one of the board members said, which is just about the common ground that I know the 9 of you have, which is that you want this to work. Like there's no, that's not up for debate. You all have your different approaches for how we're gonna get there. It's been interesting chatting more with Mary Lou because she's a former member of our HCAO board of directors and her perspective on like the concept of some sort of delay, which is not what you guys voted on today. It was voting on whether to include the entire revenue thing. And I think the arguments from Judy, Helen, and Cheryl are really powerful in that the legislature needs to see a robust plan in order to support it. But even if the vote had gone in the way you guys had voted and it was being included in this final plan, there still is no guarantee, even with legislative champions or legislative partners, there's no guarantee that our Oregon legislature in the 2027 session will actually take this up and it will become a bill, which is what this 6 years of effort is trying to get in the 2027, right? Is to get that bill. So Healthcare for All Oregon, in partnership with the Care Corps, based out of Portland, we have started a petition, which we hope we're going to amplify over the next 6 months to try to get as many signatures as we can to bring forward to the 2027 legislative session, encouraging our elected officials to not ignore the huge amount of work that you've done and to not ignore the need to turn this work into a bill that's going to work for all people. So that petition is available at the Healthcare for All Oregon homepage, hcao.org, and we'll be gathering signatures for the next several months to try to show the 2027 session that we want this plan to succeed. So, thank you.
Thanks, Scott. Mike Huntington.
Thanks, Chair Malonka and the board. I'm Mike Huntington of Corvallis. I really appreciate this in-depth collegial discussion that you had today, and I fully agree with the approval of option 3 for the reasons that were mentioned. Wanted to let you know about a microanalysis study that's being done by the Public Health Department at the University of Colorado, and its report will be given in December of this year regarding the individual savings and taxes that people in Colorado could expect. And it will be in a template form that other states can use. So I would encourage you to be aware of that if you're not already. And there will be an interim update tomorrow on One Payer States meeting tomorrow, and I'll send you all invitations by Nathan Wilkes, who is a member of the board of Healthcare for All Colorado. This is tomorrow morning, 9 a.m., July 17th, for an update on the Colorado study. Privately, they raised $750,000 to get this study done. Other thing I'd like to mention that on June 15th in the JAMA article, they talked about primary care, universal health care. And informally, I've seen interest and approval of this idea from Jim Kahn of University of California, San Francisco Emeritus, and Steve Campbell, both of whom have testified here. And as just another interest, the Oregon and Washington Healthcare for All groups have met twice in person, once here in Portland, once in Seattle, and we're meeting again in probably September, October. So I'll let people know, and I may ask some of you to come speak. Thank you.
Thanks, Mike. Lou Siniger.
1 second, Lou. You should be able to unmute and share your comment now.
Got it. All right. Oh, wait. There we go. I already lost a minute and a half or a half. Oh, well. So this has been a very robust discussion. I just want to say that one of the confusing things I think is the employer tax credit. You know, when you put up those figures, what employees will pay on a flat tax like that, it's very deceiving because they're not going to pay that much, or I don't know how much they're going to pay. I think that's a problem. The flat tax should never be presented because it's not right. So we need to figure out the employer tax credit, I think. The other thing I notice is it seems confusing to me. Well, let me put it this way. There's those on the board that want a vote in 2028 to move this along. There's those on the board that don't know, that are in doubt, that don't know what they would vote on. It seems to me like to remove the financing of the plan is kind of like, what plan will you have then? Because financing affects the benefits that will be offered. So where are you at then? What, the other thing that you need to consider, I think, is that our Oregon budget is being crashed by the lack of Medicaid funds, right? Do you think the legislators are really anxious to pour more money into this governance board? So I don't know what your legislative proposal is going to be, but we're in a hell of a fix as far as I can see. Thanks.
Thanks, Lou. Todd Ferris?
I don't see Todd online unless he's hiding in the room.
Todd, if you're participating, let us know. Okay, then Richard Gibson.
Hi, I'm Richard Gibson. I'm on the Transition Committee and formerly on the Finance and Revenue Committee. I'd like to offer that members of the Transition Committee can work on refining the options for the board on funding Oregon Health Plan. I'm sorry, on the Universal Health Plan, and do it and present it to board at the next subsequent 4 meetings. So I say, don't lose hope that we can add to that interim report and come to the legislature with a funding report that the board has agreed on. The options have been laid out in discussion, and I think with focused work of the Transition Committee and focused work of the board, that we can get to something that the board can ultimately recommend. So don't give up hope on that. Thank you.
Thanks, Richard. That's great. Did I miss anybody? Okay, great. Then I believe we have a reflection. Bruce, you got voted to give a reflection without your consent. Apologies. I told him.
You told him, okay.
That's okay. It's not the first time. So my reflection is actually an oft-mentioned quote attributed to many, which is that a crisis is a terrible thing to waste. And I say that to reflect upon the fact that, right now we are seeing, a healthcare system with all the issues and problems that we've talked about, and it only getting worse. And we do have a crisis. We have too many people who can't get the care that they need. We have a complex system. I think we all know all of the issues. And, my sense is that hopefully will drive us all to create something that's better. And let's not let the current crisis be a thing to waste, but let's reflect on that and let's turn it into positive energy going forward. Thank you.
Thanks, Bruce. Any volunteers for next month's reflection? I'm happy to do it if nobody wants to. Are you? Yeah, wonderful. Thank you. Okay, great. And with that, we are adjourned. Thank you all very much.